The agenda for today is rich and varied, addressing crucial points that form the foundation of our collective mission, which is co creating the next. Today's conference comprises of 5 panels that feature esteemed leaders from diagnostic industry. Now, let me provide you all with an overview of the panel topics scheduled for today. Today, we embark on a journey through the multifaceted landscape of medical diagnostics. We begin the forum by learning from leaders of the industry and examining how it not only steers the present but also lays the foundation for the future. As we journey forward, we will explore the cutting edge domain of smart solutions for tomorrow. Furthermore, our path will lead us to the frontier of infectious diseases and pathology best practices in the realm of testing frontiers. Finally, we will conclude our exploration by diagnosing the investment trends in the industry, followed by unraveling the advancements of radiology and digital pathology as they pave the way for groundbreaking innovations in the world of diagnostics. The next thing on our agenda would be the much awaited award ceremony. Again, I would like to express my sincere gratitude to everyone for their proactive participation. The nomination process commenced nearly a month ago, and I am delighted to announce that we have received an extraordinary response from the industry. After careful deliberation of all received nominations, our expert jury panel has shortlisted the recipients of the awards. The award ceremony shall take place in the second half of the day. I kindly request all attendees to remain until the award ceremony. I encourage each of you to actively participate, share your valuable insights, and establish connections that will play a crucial role in shaping the future of diagnostics. And with that, let the National Diagnostic Forum and Awards begin with the lamp lighting ceremony. Now, I'd like to request the following to step forward and light the lamp for our formal commencement of today's conference. I'd like to welcome Mr. Suresh Wazirani, Dr. Ravi Gaur, Dr. Naveen Nishchal, Dr. Avinash Pharke, Dr. Rajiv Gautam, Ms. Pinky Cheher, and Ms. Anu Mothuri. I request you all to please step forward. And I'd also like to welcome Dr. Sushil Shetty. I request you all to please step forward. Now, moving ahead with our day. To set the tone of the day, and without further ado, let us commence the inaugural session of the National Diagnostic Forum, Co-Creating the Next. Allow me to welcome the speakers for today's inaugural panel. To share the welcome address, I'd like to call upon stage Ms. Pinky Cheher, who is the Deputy Director at Voice of Healthcare. Ma'am, I request you to join us on stage.
Hi, I welcome you all for VOH second edition of National Diagnostics Forum and Award. And it's an honor for me to be present with all of you who are the leaders and the visionaries from the diagnostic sector. So the theme of today's session, today's forum is co-creating the next. So the phrase itself is a very powerful frame, which is like the co-creating the next. And I request everybody who are present here to collaborate, to deliberate, and innovate in the diagnostic sector, and to use this platform as an opportunity so that we can actually come up with the diagnostics main solutions, and we can make healthcare more affordable and accessible to everybody who actually deserves the best care. So with I'll not take much of the time, and with all of this, I'll again encourage everybody to use the opportunity to network and collaborate. And I thank you everybody to join us, the speakers, delegates, our partners, and the team behind the stage who has been helping us to put the forum together. And I just thank you again, and a very fruitful day to everybody. Thank you so much.
Thank you for your words, ma'am. Now, I'd like to call upon stage Dr. Ravi Gaur, Chairman, Medical Advisory Committee, Unipath Specialty Laboratory, Founder and Director, DRG Path Labs, to share his opening remarks.
Good morning, everyone. And it's my pleasure and honor to be here at this forum, talking about the inauguration at the Voice of Healthcare National Diagnostic Summit. This is second of its own kind. I think I think last year also we met at the similar forum, and I think we had a lot of learnings here. And I think the way they have carried forward, and I'm sure the same activity, the same passion, and same knowledge gain and experience we'll have in this event also. The theme today is like co-creating the next, and I think that itself speaks a lot. Today marks a significant milestone as we embark on a journey together to co-create the next, a journey into future of diagnostics. I always believe that a man of science is blind without diagnostics. We have been they are just working as a college time. I remember something about 35 years back. The teachers used to say, examine the patient, do a lot of history, and I think 80% diagnoses are met. But today it's the change. I think it's the diagnostics which they say, okay, you examine, have history, everything. A lot of tests to be done. So you come out with a differential diagnosis, a precise diagnosis, right at the day one, instead of having one, two, three, four. Any case, I think this is the ancient wisdom and the current and the new technologies together. We are trying to co-create the next, and that's the journey of diagnostics. This is something was proven in the COVID time. In the COVID, we realized without diagnostics, nothing was moving. And that's where, although diagnostics has always been there, we came in the center stage. And that's today, in fact, that tempo is still maintained. And I'm sure we have our senior, the icons here, Dr. Sushil Shah, Dr. Fadke, and a lot of other people right here. And the innovators, can see some of the new people from Haystack and Rajiv and all, Vibash, are coming out of the new things. But they're all, I think, working toward the future. But I think the amalgamation, the journey together, probably sharing wisdom will give us a lot of inputs. So diagnostic today stands as a linchpin, basically. It's like not only guiding the treatment, it's giving solutions, it's influencing outcomes. And that's something between, that means we have become almost like a center stage. We are just a pilot driving out everybody. I think all pathologists, all diagnostics, all scientists, all innovators, incubators deserve a lot of applause for that. Well done for that. Now, today, our laboratories are not just like a place of testing. That's something I remember visiting Sir Hero Shah's lab long back. And that time it was like, just they were also like, something, they will become something, the incubators of idea. That's exactly they were doing. And today, of course, all labs, all the bigger labs for that matter, are not just a place of testing, but incubators of idea, where new technologies, methodologies, and collaborations are flourishing. It's our responsibility to create an environment that encourages creativity and embark on the change. That's, I think, as a diagnostic provider, we all need to work very sincerely toward the direction. It's important to have strategic decisions, identify the right markets, right technology, allocate resources. I think, uh, it's a continuous journey. It's not or maybe it's not a like one-time kind of a destination. You have to keep moving on, and that's a necessity today. And the end, I like to just say two more things, nothing much, because we are all waiting to hear very, very senior leaders right here. You know, uh, Remember, we are turning a new page, PAGE. That's what I'm trying to pay mean. P means is a personalization. That is, personalization and precision is a very become important part of pathology. A is advancement and accreditation. I think this is again a quality is at the linchpin. We have to work on it. G is something which is genomics, molecular genomics that is getting integrated into the system. We need to adopt that. E is excellence. Whatever we do, I think we have to do with the excellence in mind, because today it's not India, not only bigger cities, rural cities and global. They're all integrated together. So we are being watched, we are being assessed, and I think every sample, what I believe is, it's a life. So whatever we do, I think we want to save a life. So let's be precise, be clear on what we're doing. With that, I'd like to thank you very much, and I think we have a long session. We have very important topics today. We have the leadership talk. We have talking about infections, which has now come back again. We have incubators, startups, even the fund management. Everything we'll be talking about what is required in the diagnostic today. Again, I thank you everybody for being here, and it's my pleasure to be spend time with all of you. And thank you so much, Voice of Health. I think the great work you're doing. Thank you so much. I'd like to actually now request Dr. Sheel Shah, who's amongst us. Thank you so much for being here, sir. He is the chairman and executive director of Metropolis. All of us are well aware. His contribution has been immense. In fact, two icons I can clearly say I'm been following. One is Dr. Sheel Shah and Dr. Avinash Phadke has been one of my mentors. I've had the privilege to work with him. I request Dr. Sheel Shah, please come to the stage and deliver his address. Thank you, sir.
Friends, ladies and gentlemen, I think that today's topic which I'm going to discuss about is the diagnostics yesterday, today, and tomorrow. Because I think that's the most relevant topic of today, and everybody's more than interested in knowing what exactly is going to be the way forward for this. Now, I remember in 70s and 80s, the laboratories used to be very primitive. The laboratories had only, even the best of the laboratories had only a colorimeter, a centrifuge, and a hot air oven, and an incubator, and a microscope, and a centrifuge. That's it. And the whole lab worked on that. There was no computerization. All the reports had to be typewritten. All the protocols for the tests had to be written down individually. So in other words, the chances of mistakes were galore. Every step you could make a mistake in that kind of a situation. So in those days, for anybody who could offer accurate and good reports consistently was considered to be a hallmark. That was something out of the way because it really required an effort. So in those days, differentiating between a good lab and not so good lab was very easy. Only the quality is what mattered. Nothing else mattered. So it was comparatively easy, but difficult to achieve. Not many could achieve this well, and that's why there was a distinction. Now, in those days, the laboratories were only single labs, which were run by the pathologists. Even the technician-run labs are not many those days, but mainly they're run by the pathologists. And these labs were standalone labs. Those days, there was not even a trend to have a collection center. It was just one lab at one place. And that is how it went by and large. So it was a very primitive practice, but it was based on three pillars. One was accuracy, as I just mentioned, which differentiated a good lab from the bad lab. And as I told you, the effort which required for accuracy in those days was probably 100 times more than what it takes today, believe it or not. Second was empathy. See, those days, the doctors, the pathologists, they used to work only for the care of the patients. There were no other factors which involved. The idea was ultimately to take care of the patients, give them a good reports, give them in time, be nice to them, talk to them. That's why the trend started in those days. Okay, the pathologists used to collect the blood sample for every patient. You'll say it's a waste of time. I say it's a waste of time. But the important thing was that brought in the empathy. Because when the doctor was collecting the blood, he was able to talk to the patient. He got 5-10 minutes to speak and talk to the patient without wasting time. And that took them a long way in developing a rapport and a bond with the patient. So I think it was a very important factor. And the third factor on which it was built was integrity. Those days, even the medical fraternity used to frown upon anybody giving any economic incentives or any kind of any malpractice, which you see rampant nowadays, which was absolutely taboo. And the medical fraternity used to blacklist the people who indulge into that. It was that clean. So that was the point in those years. Coming to today, I'm saying today means I'm talking from 1990 onwards or 1980 onwards. The accuracy has gone up dramatically because those days there was nothing to back them. Today you have got accreditations, you have got machines, automated systems, you have got interfacing, you have got computerization fully, you have got all kind of softwares to help you. There is accreditations, there is a laboratory training program for the technicians. So you have all the possible tools with you. So obviously the accuracy of all the labs have gone up. Now there is difference between lab to lab in terms of accuracy is not much because everybody has got access to these things. So now accuracy is not really, or quality, what we call so-called quality, is not a major factor. It used to be a major factor. It is not a major factor at all now. So differentiation is on a different grounds altogether. But the other two, that is empathy to the patients and integrity, I think both these have gone down compared to those days. And but natural, because empathy went down because there is no personal touch with the patients. We have so many centers, we have so many labs. Nobody can go and travel at all the places and look after them. It's so impossible. The whole scale has gone much larger for that to be there. And integrity, of course, as we know, the competition has gone up so much. Now all the laboratories, even our own, we are a publicly listed company. So every 3 months, we are asked questions about the profitability of the lab. And everybody, and 3 months also quarterly, if the profits have gone down, you have hell to answer to. So, it's all now about profitability. So in that scenario, the integrity is also going to go down. So the point is that some ways we are winners and some ways we are losers. Now, in 1990, there was the emergence of the diagnostic chains, which was a phenomenon which was not there earlier at all. I think somewhere in 1990s that it started. And it started with 3 or 4 people who started this in 1990. And that has now picked up. It has definitely brought about better standardization. It has definitely improved the quality. It has also definitely improved the instrumentation and the service to the patient because you've got more standardized service everywhere. So one laboratory means I cannot say this laboratory is better and that is not better. Every laboratory has to have a equal standard. So that has gone up. But as I told you, with this, the personal touch is gone. There is no personal touch. It's totally impersonal now. Patient is not a patient, it's more of a commodity. Everybody considers that as a sample now, not as a patient. And that is where actually the patients are lost out on. There is also a whole advent of new tests, new technology. I remember in earlier years, the number of tests which were done by a laboratory were hardly 150 to 200 upper most, 200 tests. Today, we all offer 5,000 tests, 5,000 plus. So there's a huge difference in the scales and in terms of the patient care. And as I said, the proof of the pudding is in eating. This is clearly shown by the healthcare data. They say in 1947, when we got the independence, the mortality rate was 37%. Today, it is 73% and is going up. They expect it to go in another 5 or 10 years to 80%. So there is a distinct change, and we can see the healthcare has gone up leaps and bounds. And I think diagnostics have also had a very, very big role to play in this. So I think a lot of things are for better. Everything is not for bad. Now coming to entry of this digital pathology now in last few years, which has come in. Now this has also changed the whole pathology scenario. Earlier, most of the laboratories were being run by the professionals, that is pathology professionals, either the doctors or the technicians, somebody, but it was run by the pathology professionals. Now the laboratories are not necessarily belonging to the professionals. These are now entrepreneurs who are running it. They may not be actually from the industry at all. And most of them are not from the industry. So the whole scenario has changed. Now, when this has come and all these people have come into the industry, not for the patient care, they all come in with the idea of making profit, because everybody thought diagnostic industry, there is a big profit, and a whole lot of people jumped in. It is not only the digital pathology players, even so many multinationals have jumped in now. And like we hear all the names, and they also jumped in. And everybody thinks there is a big money to be made here. Unfortunately, it takes time for everybody to realize that there is no such money in this market. So I think soon it will go out. I remember a similar stage came in 1990s when suddenly we found there were a whole lot of pharma companies and a whole lot of international players who came in the market. I remember Dr. Reddy's came into the market, Ranbaxy came. There were one or two others who came into the market for pathology lab. Then international players came in, specialty lab from California. And then came Gribbles from Australia, MDS from Germany, and then Quest from USA. All these are multinational chains which came into the market. But within 5 to 7 years, all of them disappeared. Today, none of these people are there in the market. Everybody is gone. Because after they came in, they realized that the market for their level is too small. The amount of effort required is much higher, and the returns are very poor. So they don't wait into that, they just get out of it, and they got out. I expect a similar thing to happen in this market also now. Okay, I think where the people are going to come in, they all started, but I think 90% of the new players who are coming in terms of multinationals and digital pathology players, I think 90% will disappear. I think maybe 10%, even less than that, will remain. Because this is what is a belief outside and what is a reality inside. There is a huge difference. No such thing is there which people think it's a market to go in and make a quick money and come out of this. Now, the problem with this is, with this kind of a business which has come in, the bad thing which has happened is that this has led to cutthroat competition. And because whenever there's a cutthroat competition, when new people come in, the first thing they do is they drop the prices. In any industry, the new person to make a mark is dropping the prices. So today the prices have been dropped to such levels which are not viable. And that's why all of them are going in a loss. If you see the balance sheet of all the newcomers coming, everybody is in a huge loss. So now they are trying to cover up, increase the price, and make changes. So this is actually a problem. But is this problem going to remain permanently? I don't think so. Because I think the same thing what happened 20, 25 years back is going to happen again. I think most of these people, because nobody can remain in an unsustainable market. It's out of question. So all these people, I think soon when they realize that there is no money to be made here, they'll soon gradually get out of this. So I think we expect a lot of changes to come about. The third thing is the technology changes which have taken place in this decade. tremendous. With the advent of genetics and molecular biology and metabolic disorders and all kind of new tests, new systems, new equipment which has come, I think it has made very, very, very rapid strides. And today, I feel that our market, Indian diagnostic market today, is on par with any market internationally. Because we compare the prices, I compare with the other people, and there is nothing lacking. We are doing the same. In fact, we actually get samples from many of the laboratories in USA, like Cleveland Clinic, Mayo Clinic. We get the samples from there, which they are not doing the tests. So I think today we have grown quite ahead, and we should be quite proud of ourselves that we have really achieved to make a mark in the international market. But one thing which is there, this whole diagnostic market we started with the single pathologist's own laboratories, where they used to run, give personal care to the patients and run. I think this era is on the way out. I think today for an individual pathologist with running one lab to survive is very difficult. And I expect this whole era to end within another maybe 10 years, 15 years time. I don't think it's going to be sustainable for any new person to walk in, start one lab and continue with that and survive. Very difficult. Because today everything is about the scalability. Unless you have got a scalability, very difficult to survive. But is everything bad? No. One major thing which has come out good with this advent of these new players who have come into the market is the preventive healthcare. See, earlier, nobody paid any attention to preventive healthcare. Neither the pathologists, nor the patients, nor the clinicians. The word preventive healthcare hardly was, well, the word existed, but nobody practiced. It was never existed. Today, because of this publicity which all these players have done, with the marketing they have done, they've created an awareness. And because of this awareness, now there is a whole new segment which has opened up for the pathology market, for diagnostic market, which was not there earlier. And I think which is one plus factor which has come out. One big factor segment has opened out, which is going to be beneficial. And we all know the prevention is better than the cure. So preventive pathology test is an important factor. There's no doubt about it. And that is going to carry a long way for us. So I think in coming years, the market is going to be, the diagnostic industry space is going to be very exciting, but also very unsettling, because there are a whole lot of changes which are going to occur, which are going to be unforeseen. Like these digital players who came so many in numbers, we could have never envisaged this 10 years back. Nobody thought of it. Similarly, I expect a lot of new changes to come in another 10 to 20 years time, which is going to unsettle the industry. But I think overall, industry should be better off and it should progress and do well. I think I would like to thank my talk here. I've already taken more time, and thank you very much.
Thank you so much, Dr. Shah, for your insightful talk. I would like to request you to join us back on stage for felicitation. I'd like to invite Dr. Naveen Nishchal to felicitate Dr. Shah. Now, let us now start with our first discussion. I'd like to request Dr. Ravi Gaur to join us for a group picture. I'd request Dr. Ravi Gaur and Dr. Shah to please take a seat so we could begin our next session. Now, let us now begin with our first discussion. The topic for today is leadership in diagnostics, shaping the future and navigating the changing landscape. I'm excited to call out the speakers for the panel on stage. We have Dr. Ravi Gaur, Chairman, Medical Advisory Committee, Unipath Specialty Laboratory, Founder and Director, DRG Path Labs. Dr. Sushil Shah, Chairman and Executive Director, Metropolis Healthcare. Dr. Avinash Farke, President and Mentor, Agilis Diagnostics. Sir, I request you to join us on stage. Dr. Rajiv Gautam, Corporate Officer, Horiba Limited, President, Horiba, India. Sir, I request you to join us on stage. Ms. Khushbu Sharma, Joint Director, Voice of Healthcare. Ma'am, I request you to join us on stage. Please give a huge round of applause to our panelists. Now, I'd like to welcome Ms. Khushbu to lead this discussion as the session moderator. Over to you, Khushbu.
Thank you, Tarini. Once again, on behalf of the organizing team at VOH, I would like to take this opportunity to welcome each and every one of you to the second edition of our flagship event, which is the National Diagnostics Forum 2024, which is also followed by Diagnostics Innovation and Excellence Awards. Now today, of course, it's a very special day for all of us at the organizing team and the Scientific Advisory Committee team. Not just because we are commencing the second edition today, not just because we have an amazing and enthusiastic audience with us as our delegates, and we have received an inspirational participation and inspirational, commendable, enthusiastic participation from the nominees itself, but also the fact that the dignitaries that I have on the stage today have continued their support and participation consecutively second time in a row and have participated with us as our speakers at this forum itself. So thank you so much to all four of you, sir, for your participation once again and your support that continues. The discussion today would not, so we'd be focusing on leadership, their leadership skills, their lifelong lessons, and how do they envision while they transform the diagnostics industry, and how do they envision the future of it. The outlook of today's discussion would be setting a tone in a way that we learn from their experiences, because we do have an entire agenda in front of us where we talk about technical expertise, where we talk about infectious, etc. But this next 50 minutes, we wanted to dedicate and listen to their lifelong experiences. So that's the way we'd be following the discussion. I would like to start with Dr. Avinash Farke, sir. Sir, I took the leverage and referred to some of your public interactions where you nonetheless often and emphasize on the potential of pathology and how is it impacting and has a significant importance in human health and well-being. So how do you see the role of pathology evolving throughout the years at the broader content of healthcare, specifically keeping in mind the advancements in personalized medicine and precision diagnostics? Over to you, sir.
Thank you, Khushbu, and I am very happy to participate in the second event organized by Voice of Healthcare, and it's a pleasure to interact with fellow delegates and all of you. And Dr. Sushil Shah has already explained how the lab journey has evolved in his lifetime, and I agree with him mostly. And there are few points I would like to make. Today, in terms of decision making, when we say decision making, I am talking about medical decision making. Often you will hear a grievance that today's clinicians lack clinical acumen and ask for too many tests. Now, is it true? Can you diagnose a high fasting blood sugar by examining a patient? Can you diagnose a high prostate specific antigen by looking at the patient or a digital rectal examination? You can't, because when the prostate cancer is small, forget digital rectal examination, your ultrasound will fail to detect it. And only way is to do either contrast MRI with contrast or PSMA PET scan. So these modalities have uncovered a field where the medical diagnosis today is 70% dependent on pathology tests. So a simple thing like pyrexia of unknown origin. Now you are able to diagnose on day one with PCR based cases whether your pyrexia is related to say dengue, chikungunya, scrub typhus, or it is typhoid or malaria, anything. All these tests were earlier done manually, but they are also done by PCR in today's time. So I would say, first of all, it's a myth that a clinical acumen, that's not to belittle clinical acumen or lack of history taking. What I am trying to tell you is, if there is hepatitis, you can't say whether it's hepatitis A, B, or C, or E without recourse to pathology tests. So pathology tests are playing a extremely important role in 70 to 75% of the cases of medical diagnosis. The remaining 25% get covered mostly either they are self-evident or imaging plays a role. The second thing we must remember that the pathology is moving closer to patient's bedside. So the demand of turnaround time, when the industry started, when the corporatization started in this industry in late 90s or actually early 2000, it was every CEO's dream to create a hub and spoke model where they would have a central reference lab and thousands of samples will drain from all over India, right from liver function tests to thyroid assays to fertility assays to the mother lab, achieving the efficiencies of scale. And everybody thought that's the way to go, because it results in savings. Your reagent costs are low, your trained manpower is less, and that's the way to go. But then we realize that patients want same day reports. Nobody is wanting to wait for thyroid report for 2 days now. Nobody wants to wait for tumor markers for 2 days. So whether it's your CA, PSA, or alpha fetoprotein, the report has to be released on the same day. Then this demand for turnaround time destroyed the model of hub and spoke and decentralized it. So the earlier a single lab, mother lab model is getting replaced by multiple smaller reference labs or multiple labs. Sometimes in the city, they will have 6 to 7 labs now to cater to this turnaround time. But it's not enough. You look at what has happened in emergency medicine. Today, if you go with a chest pain to a hospital, it's at the casualty or ICU that the point of care testing decides whether your troponin is high or your NT-proBNP is high and guides you to either for emergency angioplasty services or cardiac acute coronary event kind of services, or if your NT-proBNP is raised, it's a case of cardiac failure and the patient is treated accordingly. Similarly, point of care testing in US now are accounting for almost 20-25% of tests. So right from fertility to glyco-HB, all parameters are done by patient themselves. At the moment in India, it's only glucose. Most of the patients do glucose monitoring. Now you have Abbott system of continuous glucose monitoring. So patients don't come to lab. They come to lab instead of coming every month. They come once in a 6 months just to see that their glucose readings at home tally with the lab reading. So in other words, not only the hub and spoke is because of turnaround time demands and proximity of test results to actual patient bedside and advent of point of care testing had changed things in a big way. So to answer your question, these would be the major changes that the pathology plays role in majority of 70% of the clinical diagnosis. Turnaround time takes it away from hub and spoke model, and we are moving closer to patient bedside. And this would mean you will have a pocket size, your telephone like point of care instrument for molecular testing now. So your many molecular tests like your COVID test or dengue test could be done by point of care devices which are closer to the patient bedside. And I think that trend will likely to persist. And as Dr. Ravi has said, the genomics and personalized medicine is here to stay. I will just give you one last example before I end about what I mean by personalized medicine. If you look at, say, let's say, simple thing like prostate cancer metastasis, we used to do bone scans, then we used to do PET scans, and now we have a monoclonal antibody, which is a PSA antibody which is tagged to radioactive substance. So it is all replaced by PSMA PET scan. So now no oncosurgeon will ask for a bone scan. He will straightway ask for a PSMA PET scan where you know the size of lesion as well as the metastatic disease. This is achieved by tagging an antibody to your radioactive marker. So this is movement towards personalized care. And just like immunotherapy has happened in many cancers, we are going to move towards personalized care, whether it is organ transplant or so many other fields. That is another thought process and path which will emerge, that the care will not be universal, applicable to all, but it will be more personalized. Thank you.
Absolutely, sir. Thank you for that. And I'm sure that the panel also would be quantitatively be agreeing on the significance of pathology in the greater, well-being of the human health. Following to that as well, sir, Dr. Fadke, following to the significance of pathology bringing in to the excellence in diagnostics industry, you've also envisioned doctor-led diagnostic centers, which again is very evident by the establishments of Agilis Dr. Fadke labs as well. And I'm sure we have a lot many in the audience who would agree the significance of the doctor-led diagnostic centers. So how do you envision that the contribution to the delivery of qualitative medical guidance and counseling, and what impact has it had on the trust and reputation of your labs? Over to you, sir.
Yeah, I will answer your question in two phases. One, are you able to run labs without pathologists? Again, every CEO's dream that, we'll have a digital signature and we will run labs across the country by auto verification. It's possible. But luckily for us, the Supreme Court decision says that you require an MD pathologist to sign out a pathology report. So it's not gloom and doom for pathologists. They will continue to exist for times to come because it's a medical legal and compliance requirement, not only by the court, but even by NABL. You required a qualified MD pathologist to sign certain reports, and sometimes a PhD report has to be co-signed by a MD pathologist. So in that sense, without them, you can't run the labs. Secondly, you remember, we talk about digital pathology. Commonest application of digital pathology is in genetics, I would say cytogenetics, and histopathology, where you can digitally transmit the images and have an opinion. But the question is, who does the grossing of that sample? Now, suppose I have received a radical mastectomy specimen, and I have taken sections, and I have failed to detect the primary, which is just 0.3 centimeter. I have submitted sections from rest of the breast, transmitted the images to distant digital expert who signs out your report saying your mastectomy, there is no residual tumor, where actually there is a residual tumor. So this, in other words, even to do that grossing, you require a trained MD pathologist to do that grossing, because no senior medical oncologist would accept a report by a trained histopathologist where the grossing is done by an unqualified person, because it equally plays important role. Suppose there is a CA colon, whether your margins were involved, if there is prostate radical robotic prostatectomy, whether the seminal vesicles were involved, whether there was lymph node spread, Now, that doesn't take away the importance of digital imaging because you have access for second opinion, you have access for digital transmission. But if you had idea that this would result in tremendous cost cutting, that is not going to happen because even to do your grossing, you require qualified MD pathologist who is well versed with histopathology. It's not easy to dissect a radical neck dissection. And in India, where head and neck cancers are 28% of all cancers. The sad part is every fifth Indian will have cancer. That's the sad part. The sad part is that the cardiovascular diseases are now becoming equal to oncology. So you will see medical oncology is a new field which is coming up in big way with commercial PE investments in that field. The cyber knives are coming in a big way. The onco teams are creating centers of excellence in a big way. So these are all changes which require skilled manpower. So to answer your question, pathologist will always have a role to play. Of course, he can supervise larger number of tests. The need of number of pathologists can be cut down because of automation, middleware, because of auto verification. But whether we will become extinct species, not in next decade or so at least.
Thank you, sir, for that. Right. So, moving on, Dr. Rajiv Gautam. So, for you, we all know and we've read that Horiba India has now spread its presence towards the SAARC nations as well. Building manufacturing facilities beyond the borders and going to varied locations, how do you navigate the challenges and opportunities associated with it while growing the medical segments out there? And also, what considerations are taken into account when establishing manufacturing facilities and expanding the reach of diagnostic sections in different geographies? Over to you.
Thanks, Kushbu. Before I answer your question, this is my privilege to be part of this panel. My gurus are here. I can see Mr. Vajrani there. Namaskar, sir. So that's my privilege to be part of this panel first. Coming to your question, honestly speaking, neighboring countries, when Sri Lanka, Pakistan, you leave it, leave aside. Sri Lanka, Bangladesh, Maldives, Bhutan. Honestly, this is now greater India. Hardly any difference. You be in the Colombo, you feel like you are in Chennai. So people, language, everything, labs, patients, everything is same. So it is no more any neighboring countries. It is part of like a greater India, and all the diagnostics company, IVD companies, they also cover this sphere. Suppose you are in Europe or US and everything, they don't consider India as a India. They consider all this as a greater India, and everybody has presence there. The one thing you asked me about how to run it, it's very important to run it through our own people. Not normally people think to distributors and everything. So as we also Hariba run it, all this thing, we have our own team there. Everything is there. Our experts is there. Our media, marketing is there. Everything is we are doing by ourselves. That's to have to consider. Of course, foreign currency and everything. Sri Lanka was down for all these things. You have complications. You have to understand, but you have to have your own presence. That's important, and treat them as your own. It's not like a different country. So when we make a policy at Ariba and Delhi, we make it for everybody, not for just for India. So everything is almost similar, and it's growing. Bangladesh is really growing. I think sometimes we feel their GDP is better than India. So so it's really Bangladesh is really growing from this perspective. But other countries are also catching up. For IVD company, there is a very good market for us with good margins. Thank you.
Right, sir. And while we were focusing on, I'll just follow up the question. So while we are building on how we are building the manufacturing facilities, not just in India, but outside India, a very important part of setting up facilities is also to make sure that we are right ahead of the curve when it comes to technological advancements.
We don't have any manufacturing outside India. We have our manufacturing in India. We have just 2 years back, we started our Nagpur facility, big facility. I think it's one of the biggest facility for hematology in this country. So we cater it for all these regions, for the South Asian regions from India. That's how I will talk about the greater India. So it's not
All
only
right.
facilities for India, but it's for the greater situations and everything. And we need a manufacturing, make in India, and all that things is happening. So many things is happening. Customization, it's packs, India is packs and everything. And it's not only manufacturing, not only for reagent consumables, it's the instruments. Ultimately now, tenders and everything, we have to have a make in India situation. So it's not a luxury, or I think it's a mandatory for things that we make in India to make it a business in India. And that's the need. And we have a very good facility there, and we are manufacturing instruments, reagent, consumables, so many things. We are creating outside Japan and France as a Hariba, we are creating a third R&D center in India now.
Right. All right. Thank you. Thank you for that, sir. Moving on to Dr. Ravi Gaur. Sir. So you've successfully established numerous independent and hospital labs. What key factors do you consider when setting up diagnostic chains, wellness centers, and allied healthcare businesses? Over to you, sir.
Morning, everyone, once again. I think thank you so much for keeping me here. And I think again, I respect my privilege to be here with the two most icons of the industry, and of course, the upcoming person right here. When Dr. Fadke just mentioned something, he said like near patient. That's exactly one of the important factors happening in the industry. Earlier used to be a primary lab, a secondary lab, and a tertiary lab. Primary was like, okay, morning, evening reports. Secondary is, okay, I want to have report like the thyroids and torch, probably next day or third day can work. And tertiary is a high quality, like histopathology. But I think today that is changed. A lot of things from the secondary is moved into primary. A lot of things from tertiary is moved into secondary. And primary is moved into, say, point of care or even near care, near patient care. And that's a change which is happening. Now we have molecular lab, you've seen COVID labs actually happening at the district level or even probably tier 2 and tier 3 cities. And this is a change just because of technology. So that's something which is happening today. Keeping this in mind, when you set up a lab, probably we have, I think, probably across India, we set up multiple labs and seeing the various models. Dr. Sushil Shah mentioned about the satellite lab or chain of labs now coming up. And that's actually reality. First important part is I think need to see the market research. Like what is there, what is not there. You may probably a city may be having a 10 molecular lab, you're sitting in a molecular lab, will it work? That's one part. So you need to have a good market research understanding. What is the need of the place? Now, how far? Probably like say, it's about say 20 kilometers outside of Delhi. It may not work what is written in Delhi. You have to see the distance and market requirement. Secondly is the quality. I think I still always maintain, because that's what I've learned actually from Dr. Fadke right here. I remember working with him and he used to say, if you want a satellite lab, what will happen to the quality of reporting? And the quality is taken an upward stage. I think by automation, that's helping a lot. But I think quality, can you provide the quality? I think that's the second important part. Thirdly, the technology and integration. Can the technology, what you have today, it's automated. So can we have the instrument technology service available in that particular place? What technologies maybe may not be available, like Horiba is now across India, but a couple of technologies in one part of the country, another part of the country. Can the technology be there? How can you serve? Can it be served? Can it be integrated into the systems? Then comes the important part of the skilled workforce. Automation has taken care of a lot of things, but again, there's a lot of change in the skill. Is a skilled force available there? I don't know. If it is not there, what will you do? You need to train, take time, and develop the skill. Then important is the regulatory compliances. Within now a lot of state, because multiple states have got multiple regulations. Clinical Establishment Act is into place. So you start to see, will you be how much compliant, how much regulatory, keep that in mind. That's the important part. Then is, of course, the collaboration, because without collaboration, nothing is going to work. You have to collaborate with a lot of institutions, hospitals, probably the home care providers, and on the upside also, the bigger tertiary hospital, secondary hospital, that collaboration or research, clinical trial, do they have a facility, or will you, if I set up a lab in a place which is don't have much of a workload, but I can collaborate with the industry for clinical trial, probably it will help me out. So keeping that also in mind. Then of course, ultimately come the patient-centric approach. Because if I have a walk-in and probably my brand, my name is available in a small town or small place where a lot of people are coming to me, but I am not there. Those are walk-in, can I? Because it'll be otherwise they're coming one referral, second referral, third referral. So that means if I have a place, people recognize my efforts, really, why not put up a lab out there to have a more patient-centric kind of a thing? These are the important parameters we normally look into it when you set up the lab. And ultimately, I think it's all together. You have to make, and you have a last important part of resources, how much to spend, where to spend. If you put together, then only become a successful center and integrate with the local ecosystem. That's going to work.
Right, sir, right. And following to that, I mean, anyways, Dr. Phadke sir has quite envisioned about how pathology and pathologists are the core center of setting up a diagnostic center. So, you being an oncopathologist yourself, how do you envision the role of pathology specifically in the era of precision medicine? What challenges and opportunities do you see for pathologists in aligning with the principles of precision medicine?
Well, I think I'll straight away say without pathologists, nothing going to work. That goes without saying. Because they are the founder, they are the foundation. It is whatever you can. Probably we have automation, we have artificial intelligence, we have whatever. Ultimately, who's the one who's looking after integrating and putting them, weaving them together? It's pathologist understanding. A pathologist understand because the role of pathologist might change because that's because automation has happened. Your role is probably not much into the machine kind of a thing. Because earlier, I'm so sure must be seen. I think I've seen in my army days, I was in the Indian Army, that time we used to make own controls. We should do pipetting by ourselves. We should learn on those aspects. Those things are gone. Probably we have all ready-made things available today. But the role of pathologist is changing. The pathologists are important to probably also, communicate and understand and interpret. Because it's no more like one report or one value. No. It's an era of personalization, the communication. That will remain forever. Pathologists cannot change. That is something which is right. Now, when it comes to precision medicine, again, I say because you have a pathologist who's well equipped with the science, they know what's abnormal in the body, they know what physicians really their language. You can come out with a cholesterol report of value so and so, or maybe a urea report of value, creatine value, or so and so, but a protein value. But can you correlate them together? I think that's one of the pathologists report with advancement. Because clinicians, there are many advancement happening into medicine and diagnostics. I remember, like what Sushil Shah also has said, that like we used to have 200 tests at point of time. Today we have 5,000 tests. So if my clinician friend don't know about it, I also don't know about it. So I think we need to be updating ourselves and making sure that whatever the tests are there, we have a new test like infectious disease, we have infection, which is talking about how do you integrate that test, communicate to the clinician. The communication is very, very important. Though a pathologist also become like a clinical solution provider. Talk, interpret, and make sure the right test is prescribed for the better diagnosis, the faster. And when it comes to digital pathology, I think digital pathology you asked, I think has come, its era has come. In fact, I had the privilege to see one of the first digital adaptation in Shah's lab itself. Way back, they were working on a renal pathology kind of a system. But I think that's, again, I think it's not, a digital pathology, it's again supported by a pathologist. You need to create, it's an augmented tool, augmented intelligence for my pathologist, screening basic level. Maybe you have a report format out there. If you missed out certain things, they will come on the alert. And a second opinion, a third opinion. But the primary pathologist is going to always be there. There is a reluctance. There is a resistance to change because we all have been trained on seeing by the microscope. But I think gradually it is coming to place. And sooner or later, I'm sure when the medical colleges and teaching would happen on digital pathology, many people start adopting it. It's got a good tool for teaching in any case, which can always help. It can help out later on developing AI on it. But I would have a word of advice for diagnostic people. Today, we have incubators sitting in IITs, Technology Institute. They are working under, on our images. I think it's very important for pathologists to say, you have the full knowledge. Integrate, collaborate with these people. If you collaborate with the institution, the technology people who are expert, I think you have a better outcome. Because otherwise, they will work in whatever data is provided. You have the knowledge. So it's digital pathology is going to be here, it's not going to go away, but we need to adopt it. And faster we do, better it is. That's what.
Right, right, sir. If there's one common thing with all the interactions with you all, so that there's no way without the pathologist, that everything is clear, and the digital pathology and precision medicine is accepted already, and it's the way forward for all the industries out there. With that, I would come to the concluding question, a common question to all my panelists. I would like to start with Dr. Sushil Shah here. Sir, I would like to request to seek your remarks on looking ahead, what do you see as the most significant trends and opportunities in the sector? Also, a key takeaway message to some of the delegates in front of us who might be looking to venture out in the diagnostics industry. And how can the upcoming leaders prepare for and capitalize on these changes? Are there any emerging technologies or practices that you believe will play a pivotal role in shaping the future for diagnostics? Over to you, sir.
Yes. See, ultimately, everybody's worth is judged by his competence in certain things. In what actually you got a competence. Now, pathology is such a vast field. You cannot be competent at everything. You cannot be good at histopathology and this and this and this. So I think for a new people who are coming in, the very important thing is you have to specialize and become good at one particular aspect, so good that the laboratory needs you for that all the time. The rest of the things follow, because today also everybody has got a strong point. Somebody's strong point is hematology, somebody may be surgical pathology, somebody may be biochemistry, somebody may be molecular biology, anything. But nobody can be good at everything. It's not possible. So I think I would suggest if anybody new who's want to make a mark in a lab, I think it's very important you to be very good and specialize in one particular thing, particularly for which the laboratory is going to depend upon you. I think that is the way you make yourself absolutely necessary to the lab. Second thing, this pathologist's role today is very different in the lab. I mean, you just doing your test alone is not enough. You just supervising biochemistry reports is not enough. You have to be also a very good administrator, because ultimately the whole lab works with multiple people who are working under you. So unless and until you are a good administrator, I know of so many people who are very good pathologists, but they were bad administrators. With the result, they couldn't make a mark. So I think it's very important that you have to be a good administrator, and for that either it may be a great idea to do a diploma in admin. There are also now for medical administration, there are courses. Just do one of those courses, which will help a lot. But the point is you have to provide what institution requires. What is the need you have to provide for that? If you can't, then there is a problem. And then you are not going to see eye to eye with them. As I told you, the single run laboratory, I think the era is getting over. So I think nobody today in the right mind will go and start his own lab, a single lab, and hope for the best. It's not going to work. So ultimately, it's going to be either you have to be there in the hospital, or you have to be there in one of the chain of laboratories, or you can be there in probably research. These are the openings which a pathologist will have in future. Second thing, I think one of the way in which, coming to what Dr. Phadke said, coming to that point, one of the way in which you can ensure that pathologist is able to play a significant role in the lab, even if he doesn't own it. Suppose it's owned by somebody, and if you are going to be in the lab, one of the way to do it is like they have got a rule in South Africa. What they have the rule there is the laboratory starting license is given only to a pathologist, not to the person who is putting in the money. So with the result, he becomes a fulcrum point in the laboratory for all the time to come, because the license of the laboratory is his name. It cannot be given to anybody who just puts money. So pathologist continues to play, and he can probably prevent any unnecessary wrongdoings which may otherwise go in, because some businessman is putting the money and may not run it right, and you don't agree eye to eye. But then you've got a say. Otherwise, if you're just running as a pathologist in a laboratory, what is your say? You just come, you do your test and go away. And if you don't like it, then say bye-bye, then you get somebody else. You have no role whatsoever to play. So I think this is one thing which is very important. And I feel the second thing is, it is not that pathologist is supposed to sit and do each and everything in the lab, which is the normal. For everything, they'll catch the pero. Tomorrow there is something missing in the number of tests done, more than what it's required to be done, they'll catch them. They can't do it. And for this, I think it's very important that one has to uh, bifurcate the work in that. Like say Quest, for example, in US, which is the largest lab in the world. In their clinical laboratory, there is not a single MD doctor. No MD doctor. And clinical laboratory, when I say it takes hematology, it takes clinical pathology, it takes molecular biology, it takes genetics, everything. And there is not a single MD doctor there. Each department is headed by a PhD. So I think, and this is right, I feel, and the doctors are there only for histopathology. They do only for histopathology. And to make sure that doctors have their worth and their payments is worthwhile, instead of they getting into this mundane thing of running the department, their salaries are very, very high when they work in surgical pathology. I would say, simple example, they earn something like $200 to $300 per sample. So each slide they see, they earn that much. So for obviously they have to charge also more. So this is how they have brought up the histopathology at a different pedestal, which actually is a forte for the doctor. Otherwise, running a biochemistry department, anybody can do. You don't require to be MD pathologist to run that. Occasionally there may be an issue, like he says, where help may be required. But otherwise, about day-to-day basis, you don't require. So I feel that there is a niche which has to be created for the pathologist. One thing in the running of the that institution, whichever it is, in the hospital otherwise. And the second thing is where what is supposed to be his forte and what he's supposed to do there. It's extremely important. And I think if you follow this, you'll find that even more and more doctors, more pathologists, more people would like to go into pathology and do, because they learn better, they'll have the limelight, and they'll be also having a better positioning.
Right, sir. Thank you. Dr. Phadke, sir, I would like to request your remarks, please. The closing remarks.
So just to conclude, like Dr. Shah has already told you, the pathologist needs to specialize in some domain specialty. Unfortunately, in India, you have a MD degree, which is common to everything. So you are only biochemistry is separate, but otherwise, if you are clinical pathologist or histopathologist, it is post-MD, you qualify by training. Abroad, or most of the countries, your histopathology is a separate MD, clinical pathology is separate, molecular is separate. The field are separated much earlier. And like he rightly mentioned, you cannot be master of all, so you should choose your niche area. One of the other things the pathologist is expected to do in today's times, two things I would like to add to what is already discussed. One is his role in accreditation. Now the lab head is also supposed to maintain accreditation on the behalf of chain or hospital. It's a part of his job. So you should be thoroughly aware of the manual, whether it is NABL guideline or CAP guideline, the proficiency testing, and what are the requirements, the CMEs to be conducted. All these aspects the pathologist should be aware of, because now every lab would have some kind of accreditation. If you are in a hospital lab, the hospital may go in for NABH or JCI, and the lab head is supposed to know that. So one, acquaintance and mastery over all accreditation processes is a need of the hour for pathologists. The second thing, we talked about 5,000 tests. Many times we have seen, even today, the clinician is not even aware, because it's impossible. Like, I am not aware of what is available to me in imaging, for example. I don't know what different modalities of imaging are available. If you go for radiotherapy, you don't know whether there is a true beam or stereotactic or brachytherapy or a cyber knife kind of a thing or a gamma knife. Each has its pluses and minuses. Similarly, many a times the urologist or a gynecologist will ask the pathologist that this is the case. So whether, suppose somebody's semen count is normal and he is not conceiving, so it's a case of unexplained infertility. So the pathologist then can say, yes, I would like to do a DNA fragmentation on this sperm. I would like to do mitochondrial membrane potential. Similarly, there is a history of familial history of premature cardiovascular disease. You see many families where lipid profiles are normal, but the families have strong history of heart attacks at a young age. And most of these cases are just lipoprotein A elevations. And this lipoprotein A is strong genetic history. Your statins don't bring them down. There is no drug to bring them down. At the moment, there is a drug called Rapetha, which is a monoclonal antibody for cholesterol lowering. It's available in India, which brings down your lipoprotein A, but it's not FDA approved to do that. It's FDA approved only to bring down your LDL cholesterol. Now, the cardiologist in this case of a strong family history with an apparently normal lipid profile is expected to talk to pathologists that what other options are available, whether you have a role in the form of ApoB to ApoA1 ratio. Now we consider ApoB as a more atherogenic molecule than LDL cholesterol because it's combination of all bad guys. It's a combination of your LDL cholesterol, lipoprotein A, VLDL cholesterol, and intermediate density cholesterol. So world over, you will see the shift is occurring from targeting LDL as below certain level to targeting ApoB. Now, this information needs to be communicated to patient, clinician in various medical forums by talks, speeches, and that is also a role of pathologists. So apart from what is being discussed, to end, maintenance and achieving accreditations, aware of quality compliances in the country, that includes even waste disposal norms. You know that if there is a lapse on waste disposal, the company's director can go to prison up to 5 years. That's the Indian law. So the board of directors take waste disposals very seriously because the consequences are very damaging. So the pathologist needs to be aware his duty doesn't end by running a lab. If there are infectious samples, how to discard it. So maintenance of accreditation, awareness of new tests, and the test menu of 5,000 needs to be explained to relevant clinician. You will explain different test menu to a neurophysician and a different test menu to gynecologist, and you need to cover medical aspects of variety of this test. And of course, lastly, you need to be master at some field. It could be immunology, it could be molecular, or it could be histopathology. I think that's the way ahead for the pathologist as well as the lab chain. I will just end by saying what Dr. Sushil mentioned, what happened in 90s, and so many labs are not existing today, especially the multinational. It has been experienced, if you look at the experience, unlike pharma companies, at least in lab business, the Indian promoters probably do a better job than multinationals. For a Quest or LabCorp, it is difficult to run businesses in India. Secondly, some of the practices in India, they cannot indulge in because their valuation abroad will suffer and the damages and consequences are far higher. And thirdly, to liaison with the regulatory authorities, the price cap issues, you require an Indian owner to interact with the government, whether it is through FICCI, whether it is to our pathology forums, but you need an Indian promoter to proactively engage with government, whether it is Ayushman Bharat rates, which are not possible to cover your costs also. CGHS rates are better, but the payments come after 2 years. And many hospitals in Delhi didn't get paid for last 2 years. So things like that cannot be handled by multinational because their compliance levels don't allow them to handle these kind of issues. So I think not only some of them will not exist, I see a challenge more for multinational than local Indian companies. And uh, we have Mr. Wazirani with us, and he is one of the few Indian manufacturers who has made a mark in this field dominated by multinationals, whether it is Roche or Abbott or Siemens. Today we are proud to have Transasia amongst one of those. So I think the same thing will happen in pathology chains too.
Right, sir. Thank you so much, Dr. Phadke. Dr. Rajiv Gautam, sir, your closing remarks.
Not much to say after the stalwarts here, but very nicely put it by Dr. Sushil Shah that the era is over of the single labs and the largest labs, and Dr. Ravi Gaur talk about the quality and of course the genetics and the new digital things. my point is that the new things which is everybody's in this room get agreed to that we are entering into the new area of IVD, which is the digital. This artificial intelligence is coming much faster in this area than everybody we understand it. I think we normally we don't understand how fast it is getting into our lives, especially also in the diagnostics. Now we also has getting into the digital morphology now. Everybody is talking about a lab and everything, but how many professionals are there? How many MD pathology is there? How many we don't have in the villages, in the township? So I think we can still have the center of excellence in somewhere in the city, and we can have a digital something. We can get it a data reporting, something like this. So I think for a country like India, which is professionals are not there properly, there quality is not there, digital pathology is going to be, I think, is the way in the future for next 10 20 years. Maybe sometimes you have a topic of this digital morphology or digital pathology. I think this is the new situation for going forward. That's all.
Right, sir.
And
Thank
once
you.
again, thanks for being my privilege to be part of this panel.
Privilege is ours, sir. Dr. Ravi Gaur, sir, your remarks.
I think all has been said. I'll probably put into three simple words. I'll talk about QCI. I think it's not Quality Council of India. I'm talking about, say, Q for quality. Quality, whether it's your processes or accreditation or your skill or technology, adopt that. That's very important to be aware of that, number one. Number C is for, say, collaboration. Collaborate with whatever you feel. Communicate, because whether it's a global compliance or it's a national compliance or a regional compliance or a district-wide compliance, and even person or the clinician, you have to collaborate, communicate, and be a clinical support provider, clinical solution provider. Then only you will be able to be successful in the lab today, because you have to pull up that chain end to end, because that's the way it could work. And I is like invest your time in the lab, understand the processes. Money investment is also definitely needed about it. Invest your time, invest money, individualized reports. It's no more like a generalized report. It have to be individualized reports, and for better interpretation. If you do all this together, QCI, and I'm sure we have the future, we can co-create the next, and we can probably look forward 10 years from now. But we have to start today.
Thank you. Thank you, Dr. Gaur. And with that, we conclude the discussion. I think we have a question in the audience. Can we have the mic, please?
Great discussion. I'm Dr. Upendra Srinivas. I'm an MD DM, and I started my own set of diagnostic chain, so-called in Tier 2 and Tier 3 cities in Andhra Pradesh. The two key remarks that I actually want to highlight is that I fundamentally disagree with what Dr. Shah was telling, that there's no money in this industry. With an 8 billion pie of Indian diagnostic market share, I don't see any reason why there's no, especially the Tier 2 and Tier 3s are not even explored fully well. And the reason why the things are not happening the way it should is because there's no entry barrier. There are two aspects to it. One is regulation and one is accreditation. Accreditation in our country is only voluntary. It has to be made mandatory. That happens only when insurance covers the diagnostics. That is one. And the regulation is that there's no entry barrier. Everybody who has got the money bags can enter into this sector. So these are the two things why my question comes is why the top players, who are in the pole position, can influence the policy makers to look into these two aspects and make this industry thrive. And the other remark that was made is that a doctor-driven or a pathologist-driven centers in that era is over. I disagree with that, because I can be a standing example for that. I started very late in my, after having worked in a lot of hospitals, including in Mumbai. The doctor-driven or pathology-driven still has a scope, and I feel that the industry is gradually moving back towards a hyper-local model. If any competent pathologist is there in Tier 2 and Tier 3, because these cannot be penetrated by national level players who have a big reference labs at some metros, and they can't penetrate, and the sample integrity has gone nowhere. I mean, nobody is taking care of the sample integrity issues and all that. With these two things, I feel that industry can still be concentrated and get back to a hyperlocal model. We have more and more competent pathologists who want to be entrepreneurial, and as Dr. Shah was telling, that administrative skills are lacking in pathologists. If you can inculcate that curriculum at the college level, where pathologists can be a part managers also, then that would definitely change the horizons of diagnostic practice in India. These are the two remarks, and I would like to have the panel their opinions on this.
Yeah, coming to the first one, you said about no money being in the industry. I didn't say there is no money in the industry. I said the money which these people have seen, like the international labs they have seen. Let's say, for example, Quest, their turnover is $22 billion. Your whole industry put together in India will not be that much. It will be half, not even half. So they have seen at a very high level of money, and what they are going to get out of here is minuscule. Same thing about pharma companies. When they have their valuation in 50,000, 80,000, 90,000 crores, and here we are talking about 1,000, 2,000 crores. So what I'm saying, they feel that amount of energy and effort which they put into this is not commensurate with what they are doing otherwise.
The reason exactly why these players have miserably failed is because, again, it is coming to hyperlocal model, because they don't know the local, how it works, local things work. That's exactly the reason. I mean, pharma should be put an entry barrier into this diagnosis. They have no business to get into diagnostics. Why can't we adopt a South African model is my question. As somebody has rightly said in the board, if 51% is held by a pathologist, things will definitely smoothen out. That's what my suggestion is.
Yeah, but even the pharma companies left. What I'm saying is that they also couldn't sustain here, in spite of though they are from the same industry,
Right.
Then the other two things which you mentioned, I forgot. Sorry, which are the other two things which
Doctor-driven or pathology-driven is beyond its era now. That's what you commented.
See, I didn't say it's beyond era today. I said in other coming 10 to 15 years, it is going to be very difficult for them to sustain on their own. Within 10, because the whole thing is now gradually shifting. It is not a one-day process. Today it is like tomorrow. It will take a time. It will take years. Today itself, you see the standalone labs which were there 25 years back, and you see today, you don't even see half of them. Many labs have, the number has actually shrunk from that point of view. A lot of them are now technician-driven.
This trend is basically because of lack of proper regulation. Once that comes in,
that is also one of the reasons.
Yeah,
right.
Once that comes in, then probably
Correct.
Again.
Correct.
Thank you very much.
Thank you. There's one more question, please.
A very good morning to all. Myself, Dr. Jatin Munjal, hematologist at National Reference Lab, Dr. Lal. So it's an honor to be here in front of all these stalwarts and getting guidance from you all. So I echo all the sentiments and all the points that have been made, especially Dr. Avinash, sir. The TAT is a huge issue when the hub and spoke model comes into play of scalability. Along with that, I would like to add that the pre-analytical issues as well, the sample viability and stability is also a huge thing as far as hematology, coagulation, factor assays, and flow cytometry is concerned. So that also is a hindrance in that kind of model along with that. Also, I would like to add that there isn't sufficient training at the level of medical colleges when this scalability thing, automation, scalability, LIS, middleware, all these terms come into play. For scalability, it's an important thing to consider that product and consumer kind of model, where report becomes a product and the patient becomes a consumer. So as doctors or students of medicine, we are not taught those things. So I think at the level of medical colleges as well, there should be effort to inculcate these kind of administrative skills. Recently, I have been to Horiba's technical facility at Nagpur, and they have this beautiful campus. Dr. Rajiv Gautam, we had telecommunication that time as well. So they have this institute and they have a wonderful training program where we taught, we had these workshops for budding pathologists from all over Maharashtra and Gujarat. So we had workshops which included the curriculum of routine hematology, the basics of hematology, along with the automation, scalability, and middleware, remote access. So I think there needs to be more such trainings for budding pathologists as well. Thank you.
Right. I think for any further questions, we can take it down the forum because this marks the conclusion of this discussion. And I don't think there could be any better start than this leadership talk. So thank you so much to the speakers. It was an honor for me to be interacting with you.
Thank you, panelists, for that enlightening discussion. I would request you all to please stay on stage for the felicitation. Now, I would like to invite Dr. Naveen Nishchal on the stage to felicitate the panelists. Can we have a huge round of applause, please? Once again, thank you so much, everyone. Moving on with the agenda, we have a very interesting segment, the fireside chat with Mr. Suresh Wazirani on his entrepreneur journey. Mr. Suresh is the chairman and marketing director, Trans Asia Biomedicals Limited. He is a luminary in the realm of healthcare and stands as a paragon of visionary leadership with an unwavering commitment to the healthcare community. Now, I would like to call Dr. Naveen Nishchal, who is the chairman of Voice of Healthcare, to lead this discussion. Can we have both the dignitaries on stage, please?
Thank you, Dr. Tarini. How are you doing, sir, today?
I'm already feeling hot here. Can you switch on the air conditioning, please?
Thank you. So before we start this session, I would like our audience to welcome Mr. Wazirani with a huge round of applause. When we thought of having this panel and we were discussing who should interview Mr. Wazirani, I thought that this time an entrepreneur should interview an entrepreneur. So it's truly an honor for me to be on stage with you, sir. Thank you very much, sir.
Thank you. Very appropriate.
Thank you. So I'll quickly introduce myself to the audience. For those who don't know me, I'm a doctor by training. Did my MBBS, MD medicine way back in 2004. Worked for Government of Delhi for almost 4 years. And then I started a venture startup, hospital chain, Cygnus Hospital. I created 10 hospitals for tier 2, tier 3 cities of India. And during this journey, I raised investment from marquee investors like Sequoia Capital, Fidelity. And I sold my business to Amar Ujala Group. Amar Ujala is a media group Now it's Ujala Cygnus. Post that, I started another startup. It's a health tech startup, Meadow Oxford, where we are digitizing OPD prescription. And in this startup also, in last 5 years, we have built our business, and we are working with large hospitals like Manipal, PD, Hinduja, and they are using our pen in their OPDs. And during this journey also, I raised a couple of investments. So far, I have been through these fundraise and building businesses. And Voice of Healthcare, at Voice of Healthcare, we are sort of an industry connect platform. We, because of my journey, I believe that in healthcare, we work in silos, and we need a platform where all the stakeholders of healthcare, they come together and they discuss their problems and collaborate. And at Voice of Healthcare, we run an incubator as well, where I'm mentoring 4 startups in my first cohort. So that's all about me. So, sir, while I was talking about my hospital journey, my first encounter to Transasia was way back in 2010. That was my first hospital, and I bought one hematology analyzer. And that time I was not that rich, and I got that analyzer without any finance, without any interest. And your team, they were so generous because of you. I paid for that in 12 EMIs without any finance or interest. So thank you very much. That time I couldn't thank you personally, but today in front of everybody, I'm thanking you for that generous effort. Thank you very much, sir. So, sir, how many countries do you sell your equipment to? I mean, I know you are exporting your equipments in many countries. So Transasia is in how many countries now?
As of now, our products are sold in about 150 countries across the world. But our focus is mainly on developing countries, because as an Indian, I believe India is still a developing country, though we come a long way, still a developing country. Our problems are unique. Developing countries are unique problems. And I believe as an Indian, I have better understanding of problems of developing countries than anybody from developed countries. So our focus has been entirely on developing countries, the people in the developing countries, and also as a philosophy, we develop the products which are best suited for the developing countries, people in the developing countries, which mainly is focused on size, affordability. All developing countries have the same problem about affordability. Running costs should be low, maintenance should be low, all those things. So that's our focus.
So can we say that Transasia is now Trans World?
Yes, in a way. Of course, when I started Transasia in 1979 with 250 rupees, they said, Chota Muh, Badi Baat. Though 250 rupees, you're starting at Transasia. But I believe that someday we will reach there, and I'm so happy that not only Transasia, but today we are truly a trans world company.
Thank you. So, sir, I want you to, go back in 1970s. I know you have a unique quality, which is, passion for revolution, passion for change. And I have learned that in 1970s, you were following some visionary leaders. And I want to know, what is that story and how did you enter into healthcare?
Naveen, you are asking very, very interesting part of my life. 44 years of my journey in 3 minutes? Well, no, it's a very interesting journey. Many people call it accidental, but I call it destiny. I'm a great believer in destiny. I believe each one of us born what we are, or just the fact that we are here in this room is not just an accident. It's all our destiny. So this was my destiny to, as a young man, soon after I finished my engineering from Nagpur, I happened to meet some very interesting people who were working to make India a great country, who were working for the people of India totally selflessly. And me coming from a refugee family, from a very poor family, uh, you know, I never felt that I can do something for my country. I always felt that I'm the deprived one, and the whole world should come to help me. And there's nothing I can do for the world. So in that environment, I happened to meet wonderful people who changed my outlook, who gave me a new way of thinking, that even if I don't have something, but I'm born to contribute something to the world, to make this world a better place. That's the goal, to make this world a better place than what we got. So step by step, then finally, I was working closely with Mr. Jayaprakash Narayan, you must have heard about, who fought very bravely against emergency in the 70s. And it was during that time that unfortunately he had the kidney failure and had to go under dialysis every second, third day. There's a lot more to it. I'll recommend that I have a interview on the YouTube. If you see that whole story, I think you'll find it interesting to see that what really made me, think about the country, think about the world, is those incidents with Jayaprakash ji and other people.
Thank you. Yeah. So I know your journey has been, you faced a lot of challenges initially coming, belonging to a refugee family. I understand that. What I want to understand while building Transasia, because as an entrepreneur, I know that we don't become successful overnight. And building a business, it's a tough game. It takes, months, years, decade to build a successful business. I'm sure you have been facing a lot of challenges. What are those top 1 or 2 challenges you want to, talk about with our audience? You faced and you overcame those challenges. So I want to understand that also. Yeah.
First of all, when I started Transasia, I never looked at it as a business. Even though I'm a Sindhi and people say that Sindhis have business in their blood, but probably I'm an exception in that way. That was never the intention to start a business or to earn money. I was looking at the country's need. I said, how can we make India healthy and happy country? Of course, you can't be happy if you're not healthy. So it's very important that we make India healthy. And you say, how do we make India healthy? With India's limited resources, it's not easy. The modern healthcare is so expensive. All the surgeries are so expensive. So the challenge was, how do we work to make India healthy at the minimum cost? And after a lot of thinking, the answer came that prevention. We all heard that prevention is better than cure. So that's what I felt, that, if we can help every Indian prevent disease, then we can have a healthy and happy India. And how do you prevent disease? I was told, I was not an expert. When I started, I had zero knowledge of diagnostics. Probably I didn't even know how to spell diagnostics that time. But it was this conviction that prevention can be done through blood tests. Early diagnosis can lead to prevention, and that can be done through blood tests. So my dream was that if every Indian can do blood tests at least once a year, then he's empowered and equipped to know what's wrong, what he needs to do, what lifestyle change he needs to do. So that was the mission with which started Transasia, that how do we make blood testing a yearly part of our life to prevent disease, to make India healthy and happy.
Thank you very much, Mr. Vazirani. So I want to ask, for how many hours do you work every day? And for how many hours do you take sound sleep?
I don't work at all. As Einstein said that, if you're doing something that you love or that you want to do, then it's not work. So to that extent, I don't work at all. Of course, I'm busy almost 24 hours a day, everywhere. But it's a privilege. I consider it's a privilege and pleasure to be able to do this, to be able to make a difference to people's lives, to make a difference to the world is a real privilege, which I'm very proud of.
So it means you are working all the time, even during your sleep, you are thinking.
Absolutely.
And you are working.
Absolutely. Yes.
Yeah. So I'm reminded of one saying of Ghalib. I know many of you know about that. And I compare it with entrepreneurship as well. And Ghalib saying is, ye ishq nahi aasan. Ishq, let's replace this ishq with entrepreneurship. ये entrepreneurship नहीं आसान, बस इतना समझ लीजिए, एक आग का दरिया है और डूब के जाना है. So I know there are a lot of challenges, and being an entrepreneur, every day I face one hurdle and next hurdle is ready. So it's like a hurdle race. You cross one hurdle and next hurdle is there. So next topic is my favorite topic. I know that India is heavily import dependent in terms of medical devices. And you started way back in 1970s, 80s, and you are, ahead of your time. And a lot of people even, can't think that what you were thinking that time. So I want to know that in terms of growth, when did you see the big growth spurt in your business? And where do you want to see yourself in next 5-10 years?
Yeah. I mean, if you really look, each one of us looks at our own lives, you'll find that it's the challenge that makes a difference to our lives. And if you consider every challenge as an opportunity, then that's really the, what does the thing. So when I look back, it's all the challenges that really brought me where we are today. I remember in the 90s, importing was hell. You couldn't import anything. Dr. Sushil Shah will remember that when he bought my first machine in 1981. Importing machines, importing reagents, importing spare parts, absolutely hell. You have to get an import license for every single thing. An import license means at least 10 visits to the office of the government. Dr. Sushil Shah had some good contacts which I could use even that time. But so how do you run a business which is mainly import dependent? There was no manufacturing in India in diagnostics. How do you run a business where for every single thing you have to apply to the government for import license, and can take 1 month, it can take 6 months? How do you import spare parts? The machines are there working, you have to keep them working. So this was a big challenge, and I said, I certainly don't want to spend my life running in the government offices. No. I'm an engineer. I want to, bring the products, the right solutions to my customers, and certainly not spend my life running around government offices to get the permissions, import licenses. So that made me look and said, why can't I manufacture in India? So in 1991, when nobody talked about Atmanirbhar Bharat, it was out of fashion that time, I decided to start manufacturing. So 1991, we made our first chemistry analyzer. And that really, I would say, changed not only my life, but I believe the diagnostic scene in India. So since 1991, we have been manufacturing, developing, doing many things.
So yeah, I can, relate with that. In every hospital, when I was creating hospital, in every hospital, I used to buy 3 equipment from Transasia. So even if you go to any of my hospitals, you will find, Transasia equipment working in these labs. So, sir, if you are allowed to, because your journey is really very interesting, and if you are allowed to go back into your past, and if you are allowed to correct 2 of your mistakes, what would you correct out of them?
Correcting only 2 mistakes is difficult. I made so many mistakes, and I hope I can correct all of them. But if I have to name 2 or 3, which I realized recently, was that we at Transasia were not investing enough in building manufacturing capacities in India. That was number 1. Even though we have 5 manufacturing plants in India and 1 manufacturing factory in Europe, but still we're not producing enough for the whole world. For 150 countries, this is not enough. Today we have more than 100,000 machines working worldwide. That seems like a lot of number, but if you look at the total global requirement, this is very small. So I realized that we have not invested enough in the building large manufacturing facilities. So we corrected that. Last year, we put the foundation stone for our largest, what I call smart factory. So making factory is one part. How do you make smart factory for today's times, based on artificial intelligence, based on the digitization? So we set the foundation stone for our largest factory, which I believe, will more than triple our production capacity, and to meet the demand in this 150 countries. So that was one mistake. Second mistake was, after we started manufacturing in 1991, but we realized that manufacturing is only one part. The more important than manufacturing is the technology development. And as you know, in India, we have very little R&D in diagnostics. So if you don't have technology, what can you manufacture? Then you look constantly to the Western countries for technology. And I said, that's not much of Atmanirbhar. So then I realized that we need to invest in R&D, but I couldn't find any people who could help in that quickly. So we went out and bought 14 companies in Europe and America who had the right technologies, what India needed, those technologies. So we spent a lot of money. I think about over 1,000 crores we invested in buying those 14 companies in Europe and America, which gave us immediate access to technology, very selectively. We looked for a company that was a good technology in hematology, another company in biochemistry, in urine. In each area of diagnostics, we found a company who had the right know-how. So our immediate purpose was solved. But when I look back, I said, again, we are not Atmanirbhar. Buying companies in America and Europe gives us technology, but this is what I like to do. I like to make, equip India with the right technologies. So I've realized that we have not invested in training the R&D scientists to do the future technologies. So that's why result, again, last year we laid the foundation stone for a university. So you're setting up Erba University for medical technology, which will train future scientists and engineers to develop the medical technology in India, not just for India, but for the world. That was my second mistake. Third mistake is we kept on developing new machines. The laboratories also went on expanding, but we realized that the missing link is the trained technicians. We have more than 300, I think, institutes in India offering DMLT. But if you really look at the standard of those institutes, are very poor, extremely poor, absolutely pathetic. I mean, 99% of the institutes, the only equipment they have is our semi-auto analyzer. That's all they train. And in many institutes...
And most of them, they just give them certificates. They don't... Yeah.
Exactly. Most of them, so don't touch the machine. Just padh lo uske baare mein. Don't touch it. So I say, we are developing more and more advanced instruments. Who's going to operate them? How do you develop the right skill sets in the technicians? So 5 years ago, we set up our first Erba Institute of Medical Lab Technology, where we train really hands-on. It's a full-fledged, fully automated, computerized lab. And the students come from day one, they start using the equipment, learning on hands-on. So that when they're finished, they can operate any machine, they can operate the software, fully equipped to do that. So this was the third mistake we have corrected. And there are many more mistakes, but I'll stop.
I asked biggest mistakes. All of you have already corrected in the past itself. Yeah. That's great. Thank you. So if I talk about, startups of today, entrepreneurs of today, what one or two advices you want to give them and you think that they should follow those advices? I mean, this way of working and startup way of working, they believe in, burning cash. They don't think about profit for, 5 years, 10 years. So what advice you want to, give to them?
Yeah, very good question, Naveen. I explained to you that, I had 250 rupees and I wanted to start a company to make, in the diagnostics field. And of course, I was thinking that, if I can set up a small company, if I can, make 50, 100 equipment, I should be happy. This is when I met one very interesting person who said, he said the biggest sin we human beings make is that we think small. He said, if you're thinking only making 50, 100 machines, you'll do it in 1 year, 2 years, then what? No goal, no purpose. So I believe that I really realized that one mistake we all make is that we think small. So this is when I learned to, and then I called my company Trans-Asia. That, we will deal with Asian countries, deal with the problems of Asia and help Asian countries. And that has worked. That has kept me going for 44 years and still, people sometimes remind me about my age. I say, how does it matter? I don't remember my age. So if you have big enough purpose, I think half the job is done. If you take on a big challenge, big purpose, think big, then you are all set. It's a bit like, in the shipping world, all the ships when they sail before the modern technology used to follow, set their course based on North Star, the North Star. So all the ship will put their location in reference to North Star. So everybody had a North Star as their reference, as a goal. But do we know of any ship that reached North Star? No. Of course, all the ships reach their destination, whatever, and reached America, many countries. So this is a bit like this. Initially, you might think that, oh, how can I have such a big goal? But I say, if you don't have a big enough goal, what's your reference? What is it therefore to keep you going for life?
So one last question. I know you have been, really working hard, and I also got to know that you are working in social sector also. So you have some social initiatives as well. So would be good if you can, tell our audience what are those social initiatives quickly. Yeah.
Well, this is something that's very dear to my heart. So we have done a lot of work in the villages, rural areas, in education, in healthcare. But I believe that now is time for us to think of something which is not only touches on the present, but builds something for the future. So this is where our educational initiatives come in. I told you about the University for the Medical Technology, the Education Institutes, DMLT. And my next goal, big goal, these are okay, work in progress. We already started work. One thing which I would like to do as my next big project for my life is to help build leadership in India. I do believe that India is very rich in every field except the right leadership. And without leadership, not much can happen, unfortunately. It's a leadership that makes a difference, that can put, it's like a chef can make a big difference with the same spices and the same ingredients. The chef can make a big difference. So similarly, the leadership. So my next big goal is to set up a leadership university in India. Big project. I've allocated 1,000 crores for this project. And next, whatever years of my life I have, every day is a gift from God. So
May you live long, sir.
So to spend on this, to building a fantastic university, which will build future leaders in every field, whether it's medicine, health, education, service, business, in every field, build the future leaders based on values. So again, leadership is not leadership if it is not based on values. Otherwise, it's a
Wonderful thought.
Otherwise,
Wonderful
otherwise a
thoughts.
gangster.
Wonderful thoughts, sir. This man is making so much impact to not only healthcare industry, but to the entire nation. You are making healthcare more accessible and more affordable. You are truly an inspiration for all of us, sir. We really look up to you. Thank you very much, sir. Thank you. Thanks a lot, sir.
Thank you, Mr. Wazirani and Dr. Nishchal, for that engaging session. Now, I request Dr. Nishchal to felicitate Dr. Wazirani. Moving on. Proceeding to our next discussion for the day. In the rapidly advancing realm of diagnostics, the integration of smart solutions stands as a beacon illuminating the path to tomorrow's healthcare landscape. And so, I would like to introduce you to our second panel, which dives into cutting edge innovations and seamless technology integration in the realm of healthcare industry. Smart solutions for tomorrow, transforming diagnostics with tech innovation, accreditation, and standardization. Now, I'm excited to call out the speakers for this panel on the stage. Dr. Shivali Ehlawat, Director, Technical Operations, Onquest Laboratories. Dr. Akar Kapoor, CEO and Lead Medical Advisor, City X-ray and Scan Clinic. Founder and partner, City Imaging and Clinical Labs. Dr. Prashant Nag, Vice President, Diagnostics, Tata 1MG. Mr. Arpan Malhotra, Director and Chief Operating Officer, Max Lab. Ms. Anu Moturi, CEO, Kriya Group of Companies. I now request all the speakers to join us on stage. Can we please have a huge round of applause for our panelists? Ms. Anu will be leading this panel as the session moderator. Over to you, Ms. Anu.
Hello, everybody. Privileged to be here amongst such inspiring leaders in the realm of diagnostics. Thank you, Voice of Health, for giving me this opportunity. Truly an honor. I'd like to say that, gosh, I think this panel has a very tough act to follow. Right from what Dr. Fadke, Dr. Shah, Dr. Gauran, Gautam, the way they set the tone for the day, so eloquently sharing the genesis of diagnostics over the last 4 decades in India, going from fragmented hub and spoke to decentralized in the context of hub and spoke, and how we're evolving now to delivering personalized medicine at patient bedside, powered by point of care and companion diagnostics. So, wow, that was very eye-opening. Thank you very much. I would like to start by introducing myself before I go to the panel, just so you know who's standing here and speaking. I'm an entrepreneur, and I can very much relate to what Dr. Shah was sharing and what Dr. Vazirani was sharing, where after 3 decades in the US, I'm an engineer. I came back to India to invest in India and start a manufacturing, start engineering R&D and manufacturing of medical diagnostics and devices. Boy, has it been a hard decade. But it has been truly a fantastic journey so far. And I really have to take a page from Dr. Vasirani's book, inspired by his leadership. And, you know, I can completely relate to happy country powered by healthy people, because we in Kriya, our vision is delivering good health for all, powered by solutions for diagnostics and devices. So enough said about me. I think I'd like to take this opportunity and request each one of the panel members first to introduce themselves. I'd like to call upon Dr. Shivali Ehlawat, right from your side. Please introduce yourself.
A very good afternoon to all. I'm Dr. Shivali Ehlawat. I'm the Director of Technical Operations at Onquest Laboratories Limited. So Onquest started as a research lab in 2001, and thereafter it developed a niche for itself in the oncology and super specialized space. Over the years, of course, we have expanded into the entire realm, and now we have a pan-India diagnostic network. Our strong points, I would say, would be our R&D facility, the innovations we are able to bring in, our central control over all the labs, and our ability to bring out customized assays for our clients. By background, I'm a pathologist, so I'm an MD DNB in pathology, and I was into technical reporting. I was the technical HOD for one of the specialized departments in the initial years. Then over the years, I have taken over management responsibilities also. And right now I am overlooking the laboratory operations for our Pan-India labs. Thank you.
Thank you, Dr. Alawat. Dr. Kapoor?
Hi, my name is Dr. Akar Kapoor. I am the CEO and lead medical advisor at City X-ray and Scan Clinic Private Limited. So the center was started by my parents, Dr. Ravi and Dr. Sunita Kapoor, who are radiologist and pathologist respectively. My mother is a lead NABL assessor. I'm the second generation who joined my organization 7 years ago. I'm a MD radiology, and I have huge passion for radiology. And also I'm looking after the administration, the business expansion, and the growth of my organization. We have more than 15 collection centers across Delhi NCR and have multiple HLM models being part of renowned nursing homes and hospitals in our area. And I am keen, I'm part of a lot of research projects with different multinational companies, reputed institutes, and have multiple journals in reputed papers in reputed and national and international journals. I also myself perform interventional radiological procedures and have special skills in CT coronary angiography. My vision is to expand my organization beyond the borders, and we've recently started operations in the states of Punjab and Haryana. Thank you.
Thank you, Dr. Kapoor. Over to you, Dr. Nag.
Hi, I'm Dr. Prashant Nag. I'm pathologist by training and qualification and presently looking after diagnostics division for Tata 1mg.
It was pretty quick, Dr. Nag. So, hi everyone, I'm Arpan. I am a director, CEO at Max Lab. Max Lab, a little bit of flavor. So, present in more than 40 cities, over close to 50 labs in operation for more than 8 years. And this is part of the Max Healthcare Group, which we all know of. About myself, the first thing is I'm not a doctor, unlike the other three panelists.
Me neither. So you're in good
Thank
company.
you. Thanks for not being a
company.
doctor. I'm a chartered accountant by profession. I also did DCCA UK. Then I spent 5 years KPMG, 13 years in Siemens. In that stint, I was CFO for India Diagnostics. Then I became the CEO for India Diagnostics. And here I am. Thank you.
Thank you. Thank you very much. It's I'm looking forward to a very dynamic discussion because this is truly an interesting panel that's a mix of new age diagnostics businesses and also like legacy businesses that have been around for more than 2 to 3 decades. So welcome to this panel, and let's get it started. The first question I'd like to direct to Dr. Alawat. As someone who's deeply involved in technical operations at Onquest Labs, how do you see the industry addressing the challenge of standardizing reference ranges for novel biomarkers in the face of increasing complexity of diagnostic tests? And what role does collaboration play between laboratories in the standardization process? Because I understand that you have a lot of, you're a specialty lab, right? You guys actually cater to the niche market. So that I'm sure is, you have a lot of learnings.
So yeah, thanks, Anu. That's a very pertinent question in the current context. So Onquest, like I mentioned, we have, obviously being a specialty lab, we have a very well-developed R&D facility for development of esoteric biomarkers and complex, technical molecular assays for various areas, oncology, pharmacogenomics, genetics, infectious diseases. Now, any biomarker, before being introduced into clinical testing, has to undergo a detailed validation, which includes its precision testing, both intra-assay and inter-assay, accuracy, the range of measurement, what we call the AMR, the reference range, and stability testing. If it's a complex, more complex assay, even the analytical sensitivity and specificity. So there are a lot of parameters, but yes, regarding the reference range, if we just talk about that, there are basically two approaches that a lab can adopt. So the more common approach is that if there is a prior reference range given by the manufacturer in their kit or in published literature, so there is an external RI that is available, the lab can just adopt that by a verification study. So here, the population that they would need to study would be much lesser. However, there are a few points that they would need to still consider. Firstly, if they are taking it from a published literature, the analytical part, their method should be comparable. The population which they are feeding, that population should be similar to that of the RI. And of course, the pre-analytical factors have to be similar. The patient preparation, transportation, and everything. Now, coming to the second part, that is, in case the lab has to establish its own RI for whatever reason, it's not available, it's a novel biomarker, it's a research product. So we need to do that for clinical trials. There are certain biomarkers for which the reference range is not established. Then how should the lab go about it? And that definitely is more challenging for the lab and for the industry. So here what is done is that obviously you need a much larger population database. And now the challenges come in. That population database, not only do you need the numbers, you need the numbers between the subcompartments. So for any analyte, you would have, compartmentalization, age-wise, gender-wise. So getting adequate number of samples within each compartment, and the population that you are studying, that you are recruiting, it should be comparable to the population that is going to be tested. So it cannot just be your employees. If you want to, open that parameter pan-India, you want to test it at pan-India level, your reference range should include individuals from pan-India. And that is where the role of collaboration between laboratories comes in. So either if you have your laboratories elsewhere, yes, you can include them. But it would really help if multiple labs or multiple centers can recruit population. You would get a much more robust and reliable reference range. Now here again, if we go in for multi-center or multiple labs, there are at least 3 points, 3 preconditions that will have to be fulfilled. Firstly, now because you are dealing with a much more heterogeneous centers, there has to be a central reference method. So we'll consider one method to be the reference. The other methods, either all the labs are doing by exactly the same method, or their methods should be traceable to this central reference method. So that's the second point. And the third point, again, is that whatever population you are studying, yes, that should be representative. And in addition, all the labs will have to follow one common protocol for the RI, whether it is their inclusion, exclusion criteria, the statistics, the analytics, everything. So that way it is much better if, it is coordinated by some kind of central organization. In fact, recently only the ICMR, they have taken out a task force for the establishment of reference ranges in the Indian population. So it was something which was really warranted, really required. They seem to have heard our prayers, and they have made a task force for this, for which they are recruiting institutes from pan-India. So there I feel that these challenges would be addressed to a very large extent. Another related scenario, if we talk about specialized testing, is, for example, if you want to introduce a specialized molecular biomarker. So there, the reference range by itself is not that important because it's a qualitative or a semi-quantitative assay. But what becomes a challenge is getting adequate number of samples of that particular diseased population. So it might be a rare disease, it might be some kind of cancer. And here again, collaboration between labs can help in providing the samples, or if we can have a central repository or a central body from where these positive control samples can be provided. That would help at the level at the national level. We do have it internationally. They are commercially available, but yes, if we have it in India itself, it would help us to a greater extent for the specialized analytes. So that is how I would sum it up. Basically, any esoteric biomarker or molecular test, any new test that is introduced, it has to go through a detailed validation, which would include, if possible, collaboration between laboratories for these particular parts. So like the establishment of the reference range or provision of samples for rare diseases or the esoteric markers.
Thank you. Thank you very much.
Thank
Just
you.
a quick follow-on question. Do you feel that the ICMR task force, one of the outcomes that you would expect is standardization of the protocol? Because you said it would be good for all of these labs to actually come up, have a a protocol that is common and standardized, so then it becomes very
So definitely that is the criteria, among the criteria that the ICMR has kept. So first of all, in the initial stages itself, they will establish a standard protocol that has to be followed by all the institutes. There will be certain criteria on the basis of which the institutes can be recruited. They have to be NABL accredited laboratories. They have to have well-developed R&D facilities, principal investigators, everything. So everything will be properly coordinated and as per standardized methods.
Okay, so actually accreditation plays a part in this as well, which goes hand in hand with how we evolve for smart diagnostics. Yeah. Okay, great. Thank you. Thank you so much.
Thank you.
The next question is for Dr. Akar Kapoor. As an advocate for technological integration, how has AI, artificial intelligence, been specifically utilized in city X-ray and scan clinics, diagnostic processes? And part two of the question is, what measurable impacts have you observed in terms of efficiency and accuracy from incorporating this artificial intelligence into your processes?
Yeah, thank you. So basically, in an integrated diagnostic center like ours, where we have radiology, pathology, cardio, as well as neurodiagnostics, along with nuclear medicine, we use AI thickly in all departments. Talking about radiology, which is my core competence, in imaging, we are using AI since a long time. So there used to be a time when my technician used to spend like more than 24 hours in post-processing of a coronary angiography. The vessels are wrapped around the heart and he used to try to straighten the arteries and find the degree of stenosis accurately. So now with the help of these AI tools, we can very accurately do post-processing with the click of a button. It significantly helps in reducing the images, which are essential for the radiologist to make the reports. That is one. So for all the patients who are symptomatic, who are having chest pain or acute emergencies, these small things which drastically reduce the time are of essence. Even there are a lot of inter-observer variability when we do percentage stenosis. If I again talk about coronaries, so we have tools which are accurately measuring these stenosis. So the reports are more standardized and automatically the entire report is generated. In MR also, we do a lot of musculoskeletal imaging where we can do cartilage mapping. And with the help of these biochemical content of the cartilage, we can assess and diagnose early osteoarthritis. So young patients frequently come to us with pain in the knee joint or a particular joint, and we can do this MR cartogram and predict early outcomes. We are also doing a lot of corporate health checks where most of the cases are normals, which we use tools which can segregate the normals. So it drastically helps us reporting these scans faster, and we can cater to larger volumes. So we have a dedicated fetal medicine department where there is huge volume, and these ultrasounds of the fetuses are time consuming. So when we just keep the probe on the fetus with one sweep, all the measurements are calculated with the help of these machines. So it drastically reduces scan time and improves the accuracy. Also, in times of COVID, when we all faced those times when patients were just like they came at the reception and they just wanted a report as soon as the scan was done. We used tools which automatically generated the reports. Of course, they were cross-validated by the clinician, the radiologist on duty, and the percentage, the CT severity score was accurately calculated, and automatic reports were also generated. We recently cross-validated a tool for generative AI because we are also doing tele-reporting. So a lot of these radiologists, they are not in the center. They prefer working from home or even are present in remote areas. So they can just dictate the reports on the microphone, and very accurately with multiple checks, these reports are typed, and even multiple checkpoints are there. So like the other day, I was reporting a thyroid scan, and and by mistake I said pyrids. So the software automatically corrected it to tyrids. It knew that I am talking about thyroid. So these latest tools are extremely competent, and we just finished that. Oh, one more thing. Another thing, like in laboratory, like a small example, like basic test like a CBC. So we have a machine which has MP flag. So if recently, like everybody is talking about malaria elimination. So if we want to cater to bulk volumes, we need machines like these, where rather than the pathologist making the slide and the smear, the highlighters can be made as to this sample is positive for a malaria. So these are the AI tools that we frequently use, and we feel that to sum up the tools that we are using, they have significantly reduced the turnaround time, increased the operational efficiency, and also there is reduced inter-observer variability, especially talking about the radiology aspect, and eventually benefits the patients as well as the clinicians.
Thank you. Thank you very much, Dr. Kapoor. Actually, I have a follow-on question for you. When you talked about, I'm not a doctor, so pardon me if there's a faux pas. When you talked about the angiography and the stenosis, recently as last week, I had a very dear friend of mine, actually in Tirunelveli, who had right coronary stenosis. Yeah. And severe chest pain, and they had to actually do the angiography and to scan it, angiography, and then they decided to move him to Madurai. Okay, and they wanted a second opinion from somebody in Madurai and from Chennai. And what's interesting to me is with all the technology that we have today, the technician or the doctor could not figure out how to send the image to either Madurai or to Chennai. So how do you contend with this, especially with telemedicine? And you want to, all the tools that you have, I mean, we're trying to solve for the accessibility problem, correct? So we can take it down to the last mile, and we're able to deliver quick turnaround time with the type of efficiency that these tools provide us. So do you come across challenges like that, and how do you actually solve for that?
So we frequently get patients from outstation, similarly, like, who have to show to the doctor in the evening and have a flight to catch. So two things, like with the help of these tools, we can, the post-processing, since it's become faster, we can generate these scans on the CDs as well as the films much faster than we used to do. So instead of giving a time for tomorrow, we usually ask the patients to wait for an hour and probably take those CDs. Suppose if a doctor or elsewhere, someone else wants to access these images and have another opinion, then online also through, like we can transfer the images, and it can be made accessible to other parts as well.
Right. So the question that I had was, yes, we got it on a CD, but virtually a CD reader is not available these days. And the technician nor the doctor could follow the protocol to send it by email.
Yeah.
So I was wondering if you'd come across challenges like that, and how would you address that?
So, like we have different centers also, and across there we have PACS system incorporated.
Okay.
So through PACS also we can transfer these images, and these images can be made accessible to other parts very conveniently.
Okay.
By the help of a robust IT team, it can be easily done.
Okay, great. Thank you. Thank you for that response. Thank you so much. The next question is for Dr. Nag. Could you please share your insights into how Tata 1mg ensures scale-up of the standardization of diagnostic procedures across its extensive network, and how advancements in automation contribute to standardization?
Thanks for the question. So previously, also we were discussing how standardization for research is happening, how standardization for essays are happening. Then we were discussing how AI can. You were talking of, can that image go? Yes, that image can go. Only thing is adaptability on the technology in the both side. So what all is there? Why that image was not read by in Chennai? Because probably standardization was not there. If there would have been a standardization of software, that image is there, very much there, but that CD cannot be read over there because probably that software is not standardized being used over there. So let's try to understand that standardization is the basic key. When you standardize a process, that process goes into how the tasks in it can get integrated and give the desirable quality outcome in the desired time and place. So that will solve all the reach problems, the quality problems and everything. So whenever we look the whole supply chain of diagnostics in that manner, that we have to solve it for the accessibility, for the quality, and definitely the most important is standardized in a standardized manner, we get the desired outcome. We have to have the metrics of service levels, the quality, the finance metrics to be monitored, to be generated in a automated manner. So I'm just giving the why I'm talking in general right now, because see, automation, digitalization, or robotics, these are the tools of technology. The beauty of technology is difficult only for the creator. For the user, it has to be simple. So if these automation, digitalization, robotics are being standardized and used in a manner across that it is user friendly, you ought to create a system which is scalable. So if you talk about how we look at it in Tata 1mg, we see to it that whatever processes we are making, they should be centralized, they should be monitored centrally, controlled centrally, but should be able to act in a hyper-local manner. They can be monitored remotely. Just to give you an example, suppose we are proud of our sample collection module. So how it works is that we have a real-time temperature monitoring, as there was a previous discussion also, how to manage quality of samples. We all know we are all working in a pathology field, and in pathology the biggest problem is pre-analytical. Pre-analytical can be as low as, because of the temperature controls, can be as bad as the training thing that Dr. Shah mentioned in the morning, that if pathologist is not doing the right grossing, that is a pre-analytical error at the end of the day.
Yeah.
If you are not feeding the right slide to the system, they will not give the right diagnosis. Similarly, if you are doing a molecular test, you are doing a somatic mutation screening, and if you're not taking the right cut, if you'll ask your digital microscope might be trained for diagnosing the cancer, but may not be rightly trained to diagnose the slide which has the highest cancer cells density, which is required for the sequencing. It may take a slide, a section which is high necrosis. So a diagnosis of cancer can be made, but if I want to screen the mutation on that, it is not possible. So why I'm taking these different examples from today's discussion is that standardization is, if we standardize the things, we're taking all the use cases and then we plan our scale, it is bound to get to a quality scale. If we miss this in the very thing, then in the retro, we get into, we miss this quality because probably this was technical. I feel if we lay down the right technical things in the starting when we are designing our standards, we are bound to get a good scaled quality network. So
Okay.
that is how I look at it.
Thank you. Thank you very much. The next question is for Arpan. How does Max Labs leverage technological advancements in your diagnostics labs to derive actionable insights, and how are these insights translated into improved patient care and operational efficiencies, especially since you guys are integrated with the hospital, right? The hospital network. So how does that translation work, and what have you, I mean, how have you actually organized yourself around this?
Thanks, Anu. See, at Max Lab, I'll split it into, let's say, two parts on the technological advancements. One is a very conscious attempt to have high-end specialty tests done in-house, and to such an extent that the TAT really comes down. The prescribing or the clinicians are able to get a FaceTime, speak to the fraternity of the doctors who are doing tests themselves, and that's kind of a targeted, unique advantage that we leveraged on. When you take for example, pharmacogenomics, which is exactly what's needed for precision medicine. Or it's the transplant immunology. I mean, for tacrolimus, we have converted everything onto a 4-hour TET using LCMS or using a digital PCR. So the intent is very clear that now we bring it to a stage where even the samples from other countries come in, and we are able to do if not all, then most of it in-house.
Okay.
Now, sticking to this particular, the first part, I mean, while we do it on the technology and the machines we also created a data lake, so to say, so that these, the network of hospital doctors, their past experience, that gets used, and it's not restricted to some individuals. It gets translated into interpreting these, let's say, notorious cases, God forbid, if they were to come again. So that's one part, which is high-end specialty. And the other part is, I would call it patient centricity. So the entire value chain, from the first point of contact with a patient up to the point where the report is given, a feedback is taken. We're leveraging IT very strongly to an extent that it becomes online real time. So each and every activity of, including the pre-analytic, the patient, the samples coming in, the temperature maintained, the TAT given, how happy or not so happy the patient felt, which is the second part. So we kind of moved in both directions simultaneously.
Great, thank you for that response. I'd like to now move to the next segment of our discussion, which is common questions to the panelists, and looking forward to a very dynamic discussion here. The first question I'd like to ask is, I'm sure from listening to what Mr. Vazirani had said, they're building a state-of-the-art facility that is fully automated and involves technology. And honestly, at Korea, we've moved in the direction of Industry 4.0, which is fully automated and getting the complete operational efficiencies in order to churn out 420 million either test kits or devices in a year. So similar to that, I'm sorry, I'm an engineer, so I have to ask you this question. Especially when you're building to scale, I would imagine that this is something that you really want to see, where you're churning out the tests with great, with the TAT, that's the TAT as well as with precision, right? So do you think that with all the technological advances and implementation of smart labs, would you say we're moving towards Diagnostics 2.0? And what is your vision for Diagnostics 2.0 in India? I think I'll start from the far end with Arpan. Since you just finished, maybe you could start.
And keep it quick, looking at the timeline.
Yep.
So for India, Diagnostics 2.0, I mean, I would have at least 3 wishes, if I may call it so. First is the coverage and the penetration, in the sense, how many people choose to get a diagnostic test done on the wellness side, and how many who are prescribed by doctors manage to get it done in time. as well. Yeah, so the coverage, and that has to be significantly higher. And one of the reports says that in India, one person gets 1.1 tests done every year. US does 20, Australia does 10, somewhere Latin America does 5 something. I'm not saying we chase as much, we don't have insurance here, but at least, something that's more beneficial. So that's one. The second is awareness. If anybody is choosing to get let's say, a full body check or something, how do they decide which test to get done? Is it like, kadkad ki awaaz aa rahi hai, so vitamin D kara lein? Or is there, some sanity that after 45 years, this test every 6 months needs to be done? Some more awareness and guidelines. And I'll stop there.
Okay. Over to you, Dr. Nath.
So, being a pathologist has a small journey of around 15, 18 years. Diagnostic 2.0 is definitely, undoubtedly, we all are facing and we are enjoying it. There might be different cuts which everyone is looking at. Someone is looking at that as doctor-driven pathology versus organized or corporate player. Someone is looking at as predictive, preventive pathology versus diagnostic pathology. Someone is looking at it as insurance-driven versus non-insurance-driven. I personally feel these are all channels. We should look at as diagnostics as a whole is really moving at a very good level, whether it is at ease of testing, whether it is precision of testing, whether it is catalog or menu of testing. If we talk of ease of testing, right now, the collection devices have moved a way along. Genetic testings, we are doing directly from saliva, non-invasive collections, tumor markers. Proteomics is going a way ahead. Genomics is going a way ahead. With NIPT, you are testing the fetus genetics from the mother's sample. So the way diagnosis is getting deep and getting integrated with the clinical science, although financial numbers will say it will just contribute to 3 to 4% of the whole healthcare part, but it is effectively affecting the 70 to 80% of the clinical part. So yes, Diagnostic 2.0 is here, and it is something which everyone who is in the field of pathology, whether from the manufacturer side, IVD side, from the person who is performing, whether the doctor, everyone is bound to go and enjoy this phase. And I am really excited for this phase.
Great. Thank you. Over to you.
I feel that definitely the diagnostics has undergone a significant shift, especially after the COVID era. And with multiple players coming in, especially, like the non-doctor driven pathology labs, multiple chains that have come in. But the only thing I wish that everyone should keep in mind is the quality at which that diagnostic facility is being provided. That quality comes at a significant cost for the patient. When you look at the patient as a whole, if that quality reduces, the patient's entire cost of that disease or that mortality and morbidity is directly affected. So quality is something that must be kept in mind. Secondly, all the healthcare providers that are providing facilities should be open to these disruptive AI tools, as well as incorporating them in their systems to provide healthcare and at an affordable price, and also make it accessible to other parts of the country where it is genuinely required.
Thank you.
So I would just add on to what the earlier speakers have said. So starting from Arpan, I agree with him. When we talk about India, in the Indian context, yes, Diagnostics 2 is already started. It is coming. It is very exciting. But since we are such a fragmented market, we have so many contrasts, there is still some catch-up that we have to do in Diagnostics 1, which is very important, and which we know that we are largely an unorganized sector. So consolidation and organizing of the bigger corporate chains and lab chains to ensure quality of services to the last mile, that is important. That is one part which is still pending for us in Diagnostics 1. Along with that, of course, we would have the automation, the efficiency, precision, everything coming in. Now coming to the Diagnostics 2, the smart labs where we have all the integrated, lab systems, equipments, devices, the remote monitoring. I think the data integration and analytics part. The remote monitoring, it's not just of the doctor or the scientist monitoring the device at home from the lab. it is also important that the central lab is able to monitor the work that is being done in the satellite labs, what Dr. Prashant had also mentioned. So there definitely, while we have all these softwares, whether it's the logistics, the LIS, everything, it is essential that we have the API integration to an analytics, a BI software or something, where sitting in the central system, we are able to closely monitor live what is going on in each lab, whether it's the sample registrations, what is the tag, are there any amended reports, what are the problem samples, are the critical callouts going out. So similar to that, the analytics and getting meaningful insights from that, I think that would be very important in the Indian context, considering the kind of challenges we have in terms of remote areas, accessibility, and logistics.
Yeah. Oh, well said, well said.
Thank you.
Great summary here. I will wrap it up with one last question for today for this panel. Great segue into the question about data-driven insights, honestly, Dr. Alawat, where as today's diagnostics, being that we're moving into the diagnostics 2.0 era, we rely more and more on data-driven insights, right? I mean, as you rightly said, the analytics around it becomes very important. And there's also another aspect of this, which is how can the industry, what kind of strategies can the industry employ to address the concerns related to ensuring medical chain of custody of the samples, right? Which is a real challenge. I mean, I think, Dr. Nag, you touched upon it slightly, a little bit, just on the temperature monitoring aspect, but really it's the end-to-end. Being a pre-analytics manufacturer, I am so vested in making sure, right, to solve for cost, quality, and time. To the point that we've actually developed solutions for this, but ensuring medical chain of custody of the samples, data privacy, which is a big deal these days, right? I mean, when you have all of these different solution providers, IT solution providers, who holds the data, who's going to own the data, right? And what can you let them see, what can you not let them see, right? Coming from the States where HIPAA compliance is a big deal. I would say security around that and ethical use of patient data in the era of interconnected healthcare systems. I mean, how do you address the concerns around this? So I think I will start with Dr. Nag here, and maybe then we'll just finish it up.
So both for the samples as well as for data, the integrity of chain, how to make it secure is something very, very important and has to be system driven. So first touching about the samples, we need to have a very, very clear barcoded chain, and we need to keep it anonymous till the level we can. So that is the most important part when we are dealing with samples. And obviously, I'm not going into right now the analysis related integrity of the sample. That is a different whole thing where we temperature, logistics, timing for different samples, how to be segregated. Those are different things. But yes, on the basis of security of samples and data, like in data, we use bigger words like encryption, access, those things goes for samples also. What all can be accessed where, what can be given for the research, how can we make the research ethical? See, it's not just about making it ethical, it is also making it right. Because if you'll not hold it in the right way, you will miss the inclusion and exclusion criteria. And if you'll miss the inclusion and exclusion criteria, the very process of research will go non-standardized and will have a poorer results. So yes, standardization of sample sharing as well as data sharing has to be very, very strong. It's really, I take pity at times that in India, we don't have very strong compliance when it comes to diagnostics. If we come with a strong compliance on diagnostics, these things are bound to come on compliance, that how you keep your samples, how you dispose your samples, how you share your samples for research. Similarly, there has to be something on data also. There are very many guidelines, but they are not so, I would say, they are not so imposed of right now in the ecosystem. There are good labs are following them, but I think that is something which should be in place.
Yeah, I was just going to ask you just a quick follow-up. As a new age business, right, that always looks at how can we use third-party aggregators, right, for the sample collection. How does that work in terms of interoperability of data and data privacy? How do you do that?
So there are two aspects regarding Tata 1MG. One is that we have our own labs, and one is we started as an aggregator business, and we were collecting samples for other labs like top of the labs. There also we were very, very clear that order, whenever the patient is booking, one is transparency and one is holding anonymity. So it was very, very clear to the patient that your lab is, getting tested from this lab and your report will come from that lab only. And whole data integration was such that same report will flow directly. There is no holding of report at the platform level. Similarly, for the sample also, sample was pre-printed barcodes were used. It was not post-printing barcodes. So with pre-printed barcode, you can address the anonymity concern. So this is how it works if you're talking specific of how a platform should work when it is working as an aggregator.
Thank you. That was very insightful. Over to you, Arpan.
So I'll only talk about data privacy.
Yeah.
And I'll keep it short. See, I think the context for us needs to change. We need to very dearly accept that it's here. It's needed long time. It's here. Couple of years back, there was a data breach at Singapore. Some ID data got leaked, and that hospital situation was such that even phones were not allowed for quite a while. I know recently Google has been stopped from using third-party cookies. So what do?
Yep.
Is billions of revenue gonna get hyped off? I don't think so.
Yep.
So they have put their head down and said, okay, this was needed. We will come up with a topic of topics.
Yep.
So it will still happen, isn't it? So let's brace up for that. It's needed. That's all I'd say.
Exactly. Thank you. Dr. Kapoor?
Want to highlight that we need to increase public awareness amongst people that about the same issue, and also that multiple internal audits need to take place at various levels, checkpoints, so that we can ensure that there is no breach of data. These are the 2 points which I want to highlight.
Thank you. And finally, I think it's your turn to wrap it up. You started, now you can wrap it up, Dr. Alawat.
I think most of the panelists have, they've covered most of the points. So by and large, it is important that any healthcare organization, if it is dealing with the digital data, it is their responsibility to ensure the privacy of that data, and there should not be any breach. And they should follow the most stringent measures possible. So, I mean, from everything, of course, it's access control, isolation of your networks, updation, your passwords, two-step authentication, the employee training. I think that is, again, one very important point.
You hit the nail on the head.
Yeah. So the training of the employees on the risks of cybersecurity, and in case there is a breach, how should they handle it? So by and large, all those things, yes, it is very important, and it is important that it is implemented honestly by all healthcare organizations.
Thank you. Thank you very much. Time to wrap up this very interesting discussion. So thank you, panelists, for wholehearted participation and for really sharing your thoughts and for providing thought leadership to this amazing audience here. So once again, it's been a privilege. Thank you so much. And thank you, Voice for Health. Yeah, sure. Sorry? Yeah.
In their innovation or in their organization regarding all these smart wearables or smart accessories are people are using regarding to the patients?
I mean, if the question is on the patients using the smart wearables for their monitoring.
Yeah, I think that's what he asked.
Yeah. I mean, while it, kind of hurts the lab business. Yeah, but I think it's a good thing. It's gonna be here to stay, and I think the use is increasing. It's increasing a lot. I mean, Apple got into trouble for that blood oxygen monitoring, but that was for a different reason. I mean, I'll keep it short and sweet. It's gonna increase. I don't see any other way that it's gonna go.
Yeah.
And I'll just add, see, wearables are, it is really a very good thing. I was having a discussion with a fellow cardiologist. He said, although I'm getting 90% false alarms for high heart rate, but at least I'm able to contribute at least to 10% more patients now preventively. So when you talk of HRA, health risk assessment, pathology is just one part of it. Wearables is a totally a different thing, which will add a lot to the value in overall staging or giving a number to your health. So health risk assessment is something where wearables will have a long role to play.
Thank you. Are we good? Yeah. Okay, great. Thank you.
Thank you, panelists, for the informative session. I'd like to thank Ms. Anu for wonderfully leading the discussion. I would request you all to please come forward for the felicitation ceremony, and I would request Ms. Anu to felicitate her co-panelists. Dr. Shivali Ehlawat. Dr. Akar Kapoor. Dr. Prashant Nag. Mr. Arpan Malhotra. I would now request Ms. Pinky Cheher to felicitate Ms. Anu. Ms. Anu Moturi. Can we have a huge round of applause, please? I now request everyone to please come to the center of the stage for a group picture. Thank you, everyone. Moving on, we have an industry presentation on the topic Microscope for Diagnostics by Lawrence and Mayo, India. I would like to call Mr. Vijay Bhope, General Manager, Lawrence and Mayo, on stage to carry out this presentation. Please have a big round of applause for Mr. Vijay.
Hello everyone. I am Vijay Bhope from Lawrence and Mayo. Actually, engineers and doctors can build better world. I have seen that earlier presentations from Dr. Vajrani and discussions. I am again one of the engineer. I am with the microscopy field from last 22 years, and now I am continuing to give a better product for life science industry, which we can grow, and we want to be a partner for your growing profits. So Lawrence and Mayo is 147-year-old company, and we are into different segments. We have installed more than 1 lakh microscope across India, and it's counting. So yeah, Lawrence and Mayo is into healthcare, constructions, defense, and skill development industry. This is our recent client base where in last 1 or 2 months we have installed our microscope, very prestigious institute for us. And of course, you all know this Tata, then Amrita, and then Chirayu. Why Lawrence and Mayo? Like we are growing every year, literally with 20-25% rate, because we have offices across India and we do have service engineers, and complete sales office. Our delivery time, literally, I will say it's fastest delivered microscope was almost 4 hours. But maybe, when the distance is far, it may not be more than 2 or 3 days. So these are our clients which are trusting us. And recently we have a tie-up with Carl Zeiss for their range of product. Carl Zeiss, the name itself is very big and everybody knows. And we are trying to grow along with them for their B class and C class category microscopes. We do have Meiji Techno, one of the largest manufacturer of microscope in Japan. They are giving almost 5 to 6 years on-site warranty, and literally most of the microscopes are working from 20 years, and we have seen that there is no problem into microscopes. And we do have Lynx and Lawrence and Mayo, that is our own brand, where we are providing cost-effective solutions. We have discussed and seen the panel that there are a lot of medical chains, hospitals, diagnostics labs are coming up, but then there are individual labs also. So we are there to help and support both the way. When it's a big chain, we can have a lot of offices across India who can help them. And then if there is a single pathologist who want to start his lab, we do have a cost-effective microscope. Existing microscope can be retrofitted with different kind of digital things. Like in the last panel, we have discussed that digitization is going to take over. And Lawrence and Mayo is not behind. We are already, we are into karyotyping and fish. That again, it's very niche field, and most of the new labs are really want to go into it. So we have tie-up with Meta Systems through Carl Zeiss, and we can provide you completely fully automatic systems for big diagnostic chains. And then there is a standalone solutions also for a single diagnostic. So as I said, like that, we do have OptraScan with us for digital pathology, where you can have a different kind of slides, like at least from 15 slides, you can go up to 200 slides or more than that, which will provide you seamless access to the complete whole slide imaging. Through that, remotely, you can always share this data. We will provide you a complete solution end to end, where the server and everything can be taken care of, and we can guide your IT team also in this. So normally, yes, a lot of people are facing challenges with the existing microscope, that we have good service technicians with us, which are really, we are not charging very high. Very cost effectively, we are providing solutions to our clients. We do have this Zeiss microscope, starting from Primostar is their entry-level model. And literally, this is the best investment anyone can make. This is again a heavy-duty model, which is like, once somebody will have it, he need not to replace for almost a generation. This is Axiolab, which is very sturdy model and tested in the industry. Then we do have inverted microscope as well, that is for IVF solution and tissue culture labs. And then we have stereo microscope for microimaging. Sometimes it may be used in grossings also. And IVF, yes, people are using for IVF. This is a completely fully motorized model, which can be handled completely through computer. Then we have this PG Techno product, which is very rugged products, and it has been used from long time by the most of the pathologists and researchers, which goes on and on. We have never felt like that anybody using this Meiji Techno product is outdated or it's not working. It's very rugged, as everything is been manufactured in one complete factory. Mostly for cost effectiveness, people are sourcing a lot of things from different industry. But Meiji has made that each and every component of this microscope should be manufactured in their own thing, own campus, so that they can give a better quality product. Then we do have a really full setup for histopathology, which includes microtome, tissue processors, then grossing stations, and we have installed complete lab setup at few of hospitals, and we have also supplied a lot of microtomes to established laboratories in India. Okay, that is from my end. Thank you very much. And I am thank you for this arranging event, Dr. Naveen. And I'm thankful to Dr. Vivek Mendonca sir, who has given us liberty to be a part of this event. And whole of my team from Bangalore, Mr. P. Ravi, Chennai, Mr. Ravi Teja, from Pune, Suresh Rathod, and my Mumbai team is here. So always feel free to interact with them for your upcoming requirements. Thank you. Thank you.
Thank you, Mr. Vijay, for that informative presentation. I would request you to please stay on stage for the felicitation ceremony. I'd now like to call upon stage Ms. Khushbu Sharma to felicitate Mr. Vijay. Mr. Vijay Bhope. Moving on. In recent times, the world has faced unprecedented challenges posed by infectious diseases. The recent global pandemic has underscored the critical role of innovation and technology in diagnostics to manage infectious diseases. So, I bring to you our third topic of the day, exploring advanced approaches in diagnosing infectious diseases, unveiling innovations and best pathology practices. Now, I'd like to call upon stage the speakers for this panel. Dr. Nena Ingole, Laboratory Director, Molecular Diagnostics and Reference Laboratory, Kasturba Hospital for Infectious Diseases, and Additional Part Professor, TNMC and Nair Charitable Hospital, Mumbai, India. Welcome, ma'am. Mr. Ankush Gupta, Chief Executive Officer, Sterling Accurus Diagnostics. Sir, I'd like to have you on stage. Mr. Bhaumik H. Trivedi, Clinical and Diagnostics, Shimadzu Analytical Private Limited. Mr. Bivash Chakrabarti, Head, Regulatory, Quality and Government Affairs, South Asia at Biomiru, India Private Limited. Dr. Ravi Gaur, Chairman, Medical Advisory Committee, Unipath Specialty Laboratory, Founder and Director, DRG Path Labs. Dr. Gaur will be leading this panel discussion as the session moderator. Over to you, Dr. Gaur.
Well, good afternoon, everyone. And I'm sure this is lunchtime, and we never had a tea break. It's a marathon session. So I won't keep you waiting much, but very important to talk about something. What we're talking today is exploring advancement in diagnosing infectious disease. Now, infections actually, all of us have seen that. The importance. Probably we have forgotten about infectious diseases pre-COVID. It was like, okay, good, healthy lifestyle. We never talked about infections, but I think COVID reminded us infections exist and we need to really work on it. We are working on very advancements, cancer, lifestyle disorders, and we felt that, okay, good hygiene, good practices, everything exists. But when the COVID came, we realized that we are miserably left behind. So we have not really worked on infectious disease. Pathology, yes, a lot, but I think microbiology, a lot has been done, but it has not been actually used in the practical aspects. So that's something we were talking about today. It's my pleasure to I welcome all the panelists right here. I probably say let's diagnose to defeat. And that's the panel we're talking about, unraveling a path to a healthier world. In the field of diagnostic today, we have witnessed remarkable transformation. We have started manual automation to robotics. That's exactly what's happening in the microbiology or infectious disease segment too. It's a continuous learning culture, basically. It's just not an asset properly, and that's become a necessity today. So, and in infectious disease, more you know about it, more you know about the strains and substrains and substrains and sensibilities, the more detail you know about it, its knowledge becomes is more powerful. You have to know much more about everything. And they do pose a lot of challenges. I think we have seen that. The way COVID was there, I think rampant, but the way we came back, we geared ourselves well, we treated, and we have overcome it. So I think it's a big challenge. So I think today the session will like to uncover, discover, innovate. What all things are there? We have discussed somebody talking about precision diagnostic, the turnaround time, various sample types, and all this is actually very, very important today when we talk about the infectious disease. I'd like to focus on the infectious disease only, and I think move on. I think we have two other panelists are not here. So I think probably you'll be able to finish in time before you feel hunger pains for the lunch. So my first question, I think that straight away move to Dr. Nayaning. You're seeing that what are the challenges in identifying and characterizing pathogens, especially in the context of emerging infectious disease and AMR? And that's the thing. What are the basic challenges you face? And when you see the AMR, can you just share your wisdom?
So before going, I'm from an academic background and a public health background. So I think a little different from the industry perspective. Let us understand first what we mean by emerging diseases and MR. When we say emerging diseases, we always think of nowadays of COVID pandemic, as Sir rightly said. But when we say emerging diseases, it is any new pathogen which comes up or any pathogen basically which is increasing in number, or the same pathogen which is presenting have a new, maybe higher virulence, higher resistance, or maybe some new characteristics. And that is why the role of AMR also comes in, because when we are looking at, we may land up in a situation where we don't have any antimicrobials to treat. We have tuberculosis resistance cropping up, we have antibacterial, and even nowadays Candida auris resistance we're looking at, even Plasmodium falciparum resistance we're looking. So looking at a lot of, so what are the challenges when we look at it? When we're trying to do a surveillance for all these activities, basically, is that first whether we have the awareness and I think the training capacity, and whether people are aware as to what is happening, and whether they are inclined to report whatever they are observing. I think that human resource, I think, plays an important role. Second thing, if you look at the pathogen itself, we don't know what pathogen can come new or what changes it can happen. Like it had happened with Omicron when it first came in. There are very diagnostic kits which could not detect the S gene. So even if the change in even the virus was the same, but because of the change in the characteristics, there were test failures which were happening. Now we don't know the host interaction. So that again remains a challenge. Many of our laboratories are not geared up, because for any new pathogen which comes up, what we need is basically maybe metagenomics or sequencing, which we still don't have facilities about. And even a rapid test, nowadays we have molecular tests established across, but any new pathogen comes up, whether we have those kits available with the required sensitivity and specificity and at the right time. And I think the most important when we talk of any surveillance challenge would be the reporting, data reporting. We don't have ideal platforms available. And even if we do have the platform available, there's a lot of hesitancies among the people to report it. Maybe they don't want to share the data. They don't have the motivation to share it. And many times what they report is only the positive cases, increasing or the positivity, because the denominator, because 2 out of 200 and 2 out of 2000, there's a way different interpretation what you're looking at. So when we overall look at it, we have a lot of challenges, I think, when you look at, and of course resources, I think you cannot forget the resources. So there are challenges when we're trying to control, and I think that is what we have to look forward to.
I think, yes, I think very rightly said, challenges exist. And the biggest challenge today, the way I feel the rapid changes in technology is happening. You validate a technology today, by 6 months, you're getting to launch it out, something else comes up. I think, and same is happening with the pathogens in the virus. You get ready for one, they change the strain, they mutate, and something else comes up. I think we need to gear up for that. Probably one of the biggest challenge. I'll come back to you on the next question shortly. But my next question basically to is Vomik, you're here. Thank you for being here. I think I'd like to understand from you, what are the strategies for overcoming limitations in current diagnostic methods? Because there are challenges, but why can't we really, fight with them? What are the strategies? What are the basic challenges you feel in the current diagnostic? What are the limitations basically for that? And then, of course, how do you like to overcome? We'll have the next round.
Yeah. So limitations, maybe it will start with something fundamental. That is, when we're talking about the infectious disease, it's from the handling of sample, the integrity of it, because we have to also make sure that it becomes a point where it should not be virulent at a level where it will infect a lot of people as well. So it's from the handling. We have seen there have been cases where there were concerns with respect to biosafety and biosecurity itself, and it was leading to a scene where it was leading to multiple cases of infection from the source of collection itself. So it may start from that. So that is one of the limitation which I'm looking at. At the same time, we had seen in COVID cases itself, we were identifying COVID cases, but there had been multiple cases where we were unable to understand the severity of the infection itself. For example, people knew that the degraded nucleosomes or the ribosomes were one of the biomarkers which were being identified, which can really help us in understanding that what can be the severity of that infection of COVID-19. But it was never been focused. Without understanding the medications were being administered, we had seen the side effects of it. So probably understanding the severity of the infection and then understanding the therapeutic level of the drugs to be administered to the patient, by which we are not really affecting their health because of the post-infection symptoms, because of the medication which may arise. It is very much important to understand the therapeutic levels which should be administered to an individual who is infected. So I think these two are some of the major limitations which I'm looking at when we are seeing the infectious disease management. And third thing which I will also like to mention is we are looking at genomics, we are looking at sequencing, but at a preliminary stage. For example, in case of tuberculosis by itself, if we see, we are jumping on to some high-end technologies without screening the biomarker by itself. For example, the tuberculosteric acid by itself is a biomarker, and mass spectrometers have been utilized to identify those biomarkers, which can be easily be done using sputum itself. So some preliminary screening is needed to be done when it comes to such kind of disease management is concerned. So I feel these are some of the limitations which I'm looking at.
Great. I think, yes, or you I think listed almost all things. But I think we are all here to overcome the limitations. And I think we have probably our next speaker probably. And I can see a couple of people sitting in the crowd. We have Gaurav right here who's talking about overcome the limitation. But in any case, we'll come back. But I think just one limit question. You talk about severity. For my interest, does AI can help in that?
Oh, yes. I think that is a very favorite topic of a lot of people. In fact, it's even my personal favorite. I have been speaking about utilization of AI in a couple of forums in past as well. AI is doing magic. Obviously, if it has to be validated correctly, and when we are talking about patient care, we should not neglect the compliance as well when we talk about AI. Yes, when we are talking about severity in specific, yes, we need to work interdisciplinary. That is what I believe. Because when we are looking to do patient care and when we are keeping the patient in the center, we need to see from multiple prospects. Like, for example, in a lab or in a hospital, when we are getting the biomarkers getting screened, we are getting the images, we are getting the X-rays, for example, in case of tuberculosis. Let's take that as one of the example. So we are screening tuberculosteric acid. We are doing some sputum test additional to that. We are doing some cultures. We are also doing the X-rays. So with the help of this, in fact, even in case of imaging, there are advancements which are happening. The patches itself which are being identified, The designs can be identified to conclude whether it is an individual is affected or not. So when we are talking about these prospects, there should be interdisciplinary approach wherein all these reports should be pooled at a center point. There should be a by machine learning itself, it should able to understand the pattern of the infection, the level of it, and it should bring to an interpretation, which will help in solving the problems much faster, and will really help in managing a lot of patient care by itself. And in addition to that, when we're talking about infection by itself, point of care testing is something which is booming up. Now, these technologies are as small as your mobile device, and because of the 5G...
We're going to interrupt here, but we'll just come back to point of care once again.
Okay.
I was like, more like, we have that's something next round.
Absolutely.
So I was talking like, for when you said about AI, and that's, I think, field is very, very interesting, because now AI entering microbiology.
Yes.
And probably, the day I get and now we're talking about point of care, I'm sure Vivas will also talk about something on similar part. So we got a rapid testing, better turnaround time. So within a day, today you admitted, by evening you have an entire panel with you. So I know how many days I'm going to stay in ICU. What going to my bill? Probably we're looking for that, maybe like that. Because that will help us to understand and navigate these challenges of expenses and the unpredictability, and when I'm going to go well, how long I will take antibiotics and develop AMR. And AMR will put up, I think AI will play a definite role in that. We'll probably discuss that at the store.
Absolutely.
Vibhas, I'll come to you straight away, because we have a important topic to discuss today. He talked about the challenges, he talked about limitation, using, but what are the newer technologies? Because innovation is happening at a faster pace, and you are the helm of affairs. And what are the newer advancement technologies when you're talking about cutting a technology like NGS, PCR, CRISPR, so many things we keep hearing. By the time you understand register CRISPR, something else comes up. By the time registered NGS, PCR, NGS came up. I think your views on it. I think you're expert. Let me hear from you.
Right. So good afternoon, everyone. And I would like to thank the organizer, Voice of Healthcare, and Dr. Ravi Gaur. And for me, although the Voice of Healthcare is a second edition, but for me, it's the first time I'm coming to this forum. And coming to these infectious diseases and the technologies, before that, I'd like to update that pre-COVID and post-COVID. So pre-COVID, the molecular diagnostic was restricted to the premier hospitals and institutions, and it had a lot of limitations on the technology, on the various panels and equipments, and so on and so forth, technologies, and it was only restricted to few diseases. Now, what has happened during COVID is that overnight, there were more than 3,000 or 4,000 labs are having RT-PCR machine. And all these labs are also got the NABL accreditation for doing this RT-PCR test, COVID testing. So RT-PCR is now known by everyone in the country. So it's no more a buzzword. And second thing is the labs which were not having the accreditation or the good management system has got the NABL accreditation. Second, there are technologies which now no more require the clean labs or series of labs with negative positive pressure. Now, these are small footprints of instruments, does not require for sample preparation, sample separation or anything. You just take the sample, put into the systems, and everything is been done within 1 hour. And not only does one analyte, it does multiple array of analytes, let's say 20, 25, 30, including bacteria, viruses, fungi, and it's called syndromic testing. So syndromic testing means that if you have respiratory illness, it can be any viruses, bacteria, or mutant gene or antimicrobial resistant gene. And when these patients are in critical phases, their patients is in ICU, NICU, for example, pneumonia. is a disease where you need to have the diagnostics and the treatment at the same time. Otherwise, you lose the patients. And for pneumonia, the samples are very precious, and you cannot do hit and trial by doing this test, that test, series of tests, and you lose patients. And at the same time, the doctor will give the high-end antibiotics. So by doing syndromic testing, you know within 1 hour that what is the exact organisms, and you give the treatment. Similarly, it is there for meningitis, encephalitis panel. Then there are panels which are there for joint infection panel, gastrointestinal panel. So what has happened in last 5 years is that molecular testing is now no more restricted to only premium institutes. It is now being done by most of the hospitals and labs, and now it has been closer to the clinicians. So microbiologists and the pathologists are now closely working with the clinicians. It is not that the reports are being sent and it's not been interpreted. So now the clinicians get in touch with the lab microbiologist, and they do the treatment based on the diagnosis. So diagnostics post-COVID has been in the center stage. So IBD is going to have the lot of game changer in the healthcare industry. And at the same time, it has been felt by the government of India. So there is a initiative called IPHL, Indian Public Health Laboratory. And recently I was in Hyderabad and I went to the Telangana State Medical. And I was surprised to see that they do 134 tests, the basic tests and the high-end molecular diagnostic test free of charge. And they have got end-to-end system. They have got ASHA workers who go into each villages, talukas, they get the samples. Then it's been transported in the cold chain. It comes to the labs, and then it has been done. The labs are run by 24/7. Then the reports are being sent over the mobile phone. The report goes to the clinician's desktop, and then if any abnormality is there and the patient is not coming, then they've been tracked, and then they can get the district wise what are the trends of the disease. And what they said is that by doing this, they can reduce ultimately the cost of the healthcare. So if any district has got a cancer abnormalities, then they can take the decision. Then they can take the decision on the hemoglobinopathy. So various things. So what has changed is now the diagnostics it's no more a lab test. It is now been used by the doctors and for various decision making. For example, antimicrobial resistance is no more a buzzword. It's now being felt by not only the microbiologist, but everyone. But in India, it's still a long way to go because of different things, because of the regulation, availability of the antibiotics over the counter in chemist shops. And also, it is now the infectious diseases is now going to be here because it's not that the infectious disease has got any boundaries. So there are more infectious diseases are going to emerge, but what is important is that now there are various point of care testings and molecular diagnostic testings has now become more easy than before.
Thank you. That's something very interesting because that means like we are now, near patient, near doctor, near clinic. And a POCT coming up, I think we know certain instrument like BioFire, we have almost like a point of care testing. We get reports within 2 hours and multiple. I think more important is equally important will be multiple sample types and a turnaround time. That's something which is, I feel is a changing thought which is going ahead. So I think, I'll come to Bhomik, your, this question. Now, when there's so much of infection is happening, new technologies are being detecting kind of thing. So how do you keep, the lab personnel safe from them? That's very important because do you think they require constant monitoring, testing, at the kind of biometrics you enter, inhalers? what is the like best way? Because we have a little short of time, but a little short. Can you just brief it?
Yes. So quickly, I'll just touch the point. I mentioned previously as well, the biosafety and biosecurity, something is really very thing to be focused when we are talking about infectious panels and infectious testing. So the best way of doing and maintaining the biosafety levels in the lab is certainly the continuous education, which needs to be done, because somebody mentioned in the previous sessions as well that the technicians, when they are in their universities or in their colleges, they're not being trained to the level at which they are supposed to work in the industry. So I think that is one of the way where the industrial community, like us from industry, we should come together and try to train the technicians that how they should manage it. At the same time, the engineering facility, the infrastructure which is being made up in the lab will really contribute a lot, because though we are saying that there have been labs which are free from those negative and positive pressures, but there are certain concerns which are still getting arise. So these restrictions are bound, and we need to follow that, because again, in past session, somebody mentioned that if something goes wrong and if the biosafety levels are not being maintained, it's not the technician, it's not a doctor, but the founder of the organization is something who gets prison for 5 years, and that is the norm which India is following. So yes, we need to focus on this. So education is one of the important factor, and the the engineering setup of the lab is also another important factor which I'm looking at.
And I think I can see, breath air coming in. Because, just like whether it's a lab or hospitals or a community or malls, probably you enter, breath, and you'll probably have analyzed the bacterial flora, whatever it is, or how severity your AI will help out in the severity too. And of course, that's brings to the next question to Dr. For that matter.
Just this
The next question.
previous question, I just like
Because when we talk about infections, we're talking about the surveillance actually. Surveillance is very, very important. And so, we are all seen. Moment it's an infection, we feel about, oh, I'll get infected, community get infected. So I think how important is the role of surveillance, and how to build up collaboration, and especially early detection. And of course, I think the way the world is becoming global. So I'd like to have your views on this, and you can answer whatever you're heading to, please.
Okay. I just want to add a point to Dr. Bhaumik said. It's also important when you're talking of biosafety, biosecurity, to know what level of organisms you're talking about. So because that risk assessment also, I think, is very important, because that is where the engineering structure would come to. Now, coming to the question which has been put to me, there are two parts. I'll go for the surveillance importance first, just for the interns and etc. here. But when we mean by surveillance, the definition itself says it is data collection, analysis, interpretation, dissemination for public health intervention with the ultimate goal of disease control and prevention. So when we talk of surveillance, you have to monitor the diseases so we know what is happening, how the diseases are spreading, which area they are spreading. So we can have an early detection of the diseases, early reporting of the diseases, so that we can have good interpretation, good intervention, so that it doesn't disseminate too far and we can control it fast. Now for this, when we're looking at surveillance, we have to have certain strategies in place. And I think that is where we lack today, because there's a lot of intersectoral collaboration which would be required. And right now, I think there's a big divide between the industry, the private sector, the public sector, and between the different policies what we have. So first, we need a uniform platform or strategy on which we are all going to work together. And for that, another thing what we need is basically the common SOPs or the practices which are going to be followed, because even the kits what we use, we know that they have all different sensitivity, specificity. I'm reporting a test with say IgM or IgT test, somebody is reporting with an antigen, PCR test. Obviously there will be going to be differences. So when we are talking of any surveillance, first there has to be uniformity in reporting, there's a uniformity in the standardization of the SOPs that we are going to use, and then we talk of the training and capacity building. Because unless and until people are aware, as I said earlier also, they are not going to report any of the diseases, and we are again going to land up even whatever beautiful platforms we have for that. And obviously public-private partnership, intersectoral collaboration. These two also play a major role in dividing. Now we have a lot of surveillance going on, which can be any active surveillance, passive surveillance. We also have disease surveillance. Like we have an influenza program, surveillance program, which is run by the WHO. And we also have sentinel surveillance, like what we do for our HIV. But I think what we have basically is more of a passive in our country right now, and which has to go on an active mode. And many times we are not reporting, I think, and that's where I think we have to really work on. But I think COVID has taught us, because whenever the ICMR portal was there, we have got used to reporting all the testing that we're doing. So I think if we take the same thing forward, I think it can help us to build those strategies, and I think it will help us to achieve that reporting and identifying the disease early so that it doesn't spread and we can control it faster. Thank you so
Thanks.
much.
I think that's something what we've done in COVID should continue, and probably the bigger pace, better analyze. Vibhas, like just quick question. We have just a couple of minutes left. Because you're into the manufacturing also. What we're talking about? We talk about breath air. Do you think more POCTs or more are coming, and something in your update? What's happening on the early diagnosis and many sample type?
Okay, so POCT is going to stay. POCT is also one of the need, because when a patient comes to a physician, and it's more in popular in US, which is called physician office lab, and the doctor do the diagnosis on the clinic itself and give the treatment. But except in India, POCT, except some rapid test, is not that popular, because first of all, the doctors themselves do not do the tests because of several regulations. But POCT, as such, there are many devices are coming which are closer to the patients, and it is that patient need not have to wait for 1 day or 24 hours or 48 hours. They can get the first-hand information at least as soon as 1 hour, 2 hours, within 2 hours. Now, for example, there are molecular devices. For example, Spotfire. A patient comes to a clinic for a respiratory illness and being diagnosed in 15 minutes for a RSV. So, which is a game changer, because you have seen that the journey of COVID, there are so many mutations are there, and we do not know that which is the causative agent and how it done. Now, POCT for a pediatrician to do a test in 15 minutes and give the result, and the charges which is not covered by the insurance is going to be acceptable by the patient, yes or no?
No.
Because if you see the cost of diagnosis in a hospital vis-a-vis the cost of the length of stay, the cost of the high-end antibiotics, if you do a diagnosis, because in India, the insurance penetration is still not at very high, and the out-of-pocket expenses still more than 60% today. So the cost of treatment and the cost of antibiotics, the length of stay, vis-a-vis the diagnosis at the need of the hour, and the targeted treatment is more important than the diagnostics cost itself by itself. So I think this is changing. The clinicians are also getting more aware, and they are more demanding, and they are also now asking for the report and the feedback from the microbiologist, from the pathologist. So it's a good time that the clinicians are also getting the interest, and the new age clinicians, and because of the awareness, because of the internet, and because of the post-COVID awareness, the things has really changed. Now the lab and the clinicians are working very closely, which is a really good sign.
That's nice to know. I think the POCT has arrived. I think the more microbiology, the pathogens are arriving, the more the armed we are going to be. I think in the that's it. Probably we have a time's up is already written out here, but I will take 5 more minutes before I sum it up. Because, like very important, I feel that I started with, when it comes to infectious disease, knowledge is the power. So I got to change the text instead of asking the audience. I like somebody, I can see someone sitting in the audience who was actually talking about the investment, bringing the pricing down, how you turn around, how you make the test happen at the or the point of contact. That's right, like. So I think, Gaurav, can you just share 2 minutes? I think you can have just 2 minutes. Because he's doing phenomenal work in tuberculosis and maybe some other infectious disease. I just like 2 minutes of yours. That's it.
Absolutely, Dr. Gaur, thank you for giving me this opportunity. A fantastic talk with the panel here. I think we are just starting up with our work in genomics. So Haystack, my company, is working in genomics and focusing on infectious diagnostics. What we are seeing today, the problems that you mentioned, Dr. Nana, the infections is a very wide problem, and it is ever changing. The scope of it is increasing by the day. New pathogens, new mutations. How many kits are you going to work with, right? So I think that is where our thesis is. PCR-based technologies, they are making diagnosis of assumptions faster, but they still have their limitations. Comprehensiveness of the test, the width of spectrum that you are able to cover is going to be the perfect solution for the market. And that is where we think genomics as a technology is going to be the game changer. I think the world has understood the association of the analyte DNA with the advent of molecular that has happened in the last 20 years and last 5 years in India that ways, with the disease condition, with the infection per se. Now, taking it to the next level where we are able to use this understanding, but accelerate the coverage of pathogen that we are able to bring in, make the diagnostics kit independent. Don't need to test for dengue, don't need to test for E. coli. Test the sample to know what there is. That is the opportunity that genomics can unlock. And that is where we think new technologies is going to make a significant dent in how patient outcomes can be impacted positively. That's our view. And we also believe at scale, just like PCR, the cost of the technology came down significantly. Genomics is going to become a replacement of, or possibly at par with culture at the right scale. And that's where possibly 5 years hence, the world is going to be sitting at.
That's nice to hear you. Thank you so much. And I think the first thing I talked in the morning was PAGE, P-A-G-E. P was like personalization, A was advancement, and G was genomics, and E is excellence. I think all three together in diagnostic. With genomics has arrived. POCT is also arrived. With this, I think I thank you all the panel. I can sum up by saying that, change is the only constant when it comes in our field. And it's our ally. We must be agile, flexible, and guiding our team through the waves of change. That's very, very important. Help them around to navigate the uncharted territories. And this is where we're heading for. We don't know before COVID. There could be so many strains of COVID, and which strain will come further, we don't know. Finally, our North Star, actually, I'd say, must always be the patient. Everything what we do should be patient-centric, and every decision will be like helping the patient and, of course, better clinical outcomes. And today we stand on the platform of transformation. Let us, in this embrace journey with open minds. Let's talk about innovation. Let's be incubators. Let's collaborate together. Let us integrate. Let's adopt all technologies and learn from each other. Otherwise, technologies come and go because they keep the left in one corner. Somebody adopts, somebody is not aware. The awareness, everything is very, very important today, and integration is equally important. Together we can shape the future of diagnosis, navigate healthcare landscape with vision, courage, and relentless pursuit of excellence. That's a must. Thank you so much. Let the journey begin. And thank you so much for everybody. Thank you.
Thank you, panelists, for an insightful discussion. Thank you, Dr. Gaur, for your words and moderating the session. I would now request all of you to come forward for the felicitation ceremony. And I would like to request Dr. Gaur to felicitate his co-panelists. Dr. Naina Ingole. Mr. Bhaumik H. Trivedi. Mr. Bivas Chakrabarti. I would now like to request Ms. Pinky Cheher to felicitate Dr. Gaur. Dr. Ravi Gaur. I request everyone to please come together for a group picture. It is now time for our networking lunch. Post-lunch, we will reconvene for our next panel discussion. Please enjoy your lunch and take this opportunity to network and connect with your fellow attendees. I request everyone to gather